And also, we greet those who are joining us via Zoom. To begin the international seminar on inequalities in access to health and the centrality of primary health care to advance towards universal health, I hand over to Alberto Arenas de Mesa, Director of the Social Development Division, ECLAC. Thank you, Maria Luisa, and good morning, everyone. And on behalf of the Economic Commission for Latin America and the Caribbean, ECLAC, I would like to cordially welcome you to this international seminar on inequalities in access to health, the centrality of primary health care to advance towards universal health. And that at ECLAC, we are organizing within the framework of the project implementing at the Social Development Division and the UN Development Account, Resilient Health Systems with Universal Coverage in LAC. First of all, I would greet our authorities here in person who are part of the project. And I would like to cordially greet the Undersecretary of Assistance Networks, Ministry of Health of Chile, Dr. Osvaldo Salgado, and thank you, Undersecretary, for being here with us in person at ECLAC, and also greet the team of the Ministry of Health that is with us here today. And also Dr. Edwin Mantufa, who is Vice Minister for Primary Health Care in the Ministry of Health and Social Assistance of Guatemala, and whom we are also pleased to welcome. Thank you, Vice Minister, for the long trip to be with us here in Chile at ECLAC, both you and your team. And I would also greet Dr. Asa Cristina Laurel, who is the Director of Strategic Planning for Institutional Transformation at the Mexican Social Security Institute, and with whom we have been working in recent years. Thank you, Dr. Laurel, for the video sent from the Mexico City and for the presence of your team here through Mr. Raciel Ramirez. And likewise, a special greetings to Dr. Jaime Urrego Rodriguez, who is the Vice Minister for Public Health and Health Benefits from Colombia, who will be with us in panel 1 online from Bogota. Thank you. And of course, each one of you, I thank you for the confidence that you've had in ECLAC to accompany us in our expert moving towards greater levels of universality and resilience in the health systems in your countries. And also, I thank each panelist and moderator who will be with us throughout the seminar, both in person as well as online. And among others, we will have participation by the French Development Agency, PAHO, IDB, WHO, OECD, Video Cruz, and so a seminar with regional participation of significance. Your valuable experience and analysis will allow us to elaborate on current discussions on the main obstacles and barriers that the people face in accessing health services, as well as the relevance of the strategy for primary health care toward moving towards universal care. And I thank you for your time and disposition to share with us the lessons learned regarding universal health access and coverage. And finally, I thank our audience online as well as in person, and everyone who supported the organization of this international seminar on health in its various dimensions at ECLAC, and especially the team at the Division of Social Development headed by Maria Luisa Marinho, supported by Antonia Marawe, and at the end I will greet everyone. This seminar, the first international activity of the UN Development Account Project Resilient Health Systems with Universal Coverage in Latin America and the Caribbean, and that aims to support the countries of the region to design, adapt, and implement institutional macros and policies that promote universal health systems that are resilient and sustainable to meet the 2030 agenda and better face the various ideas and crises that may appear. The COVID-19 pandemic showed the structural weaknesses of American health systems in Latin America and the Caribbean, highlighting their chronic underfinancing, segmentation, and fragmentation of the health systems. And this has been characterized by scarce spending in health and a high out-of-pocket expenditure and segmentation of health in different subsystems that are not related and fragmentation of care and organization of these systems. And so these weaknesses translate into issues related to access and efficiency, coordination difficulties, a lack of solidarity and inequality were obstacles to universal health accesses, and the crisis of the pandemic showed these weaknesses in addition to deepen the difficulties to access timely health care. And this had a particular impact on more vulnerable populations, as well as people living in poverty, indigenous people, migrants, people with disability, among others, whose health is negatively affected by inequality or unequal distribution of the social determinants of health that in turn is conditioned by the structuring axes of the social inequality matrix. And likewise, the pandemic showed unequivocally that without health there is no economy, as we were talking with the Vice Minister of Guatemala. Without health there is no development, and in this context the health of people and is a priority, but also must be considered at the heart of the construct of successful strategies for inclusive and sustainable social development. And among other factors, ECLAC has highlighted the historical opportunity experienced by the region to discuss and further in transformations of the health system, moving towards universal care, sustainability of the system. The call is to strengthen health systems with a rights-based approach and universal care sensitive to differences and responding to the specific and differentiated needs of people, together with a sustained increase in health investment and connection among the various segments of the health system to overcome inequalities in terms of access. As we will see here, primary health care has a great potential to ensure the right to health and reduce inequalities through services, treatments, and rehabilitation, among others. The social determinants of health and in close connection with the society and the changes that digital technology may enhance. And so the idea is to consolidate investment in primary health care. Likewise, it is essential to increase resilience of our systems, improving the coordination and articulation between health systems and social protection systems. And on account of this, we're convinced that investing in health systems in the region is related not only to ensuring the right to health for the population, but also achieving the successful strategies for social, inclusive, and sustainable development.
And to be able to end with my words, today I would like to first share the following thought. The pandemic generated a crisis, a health crisis, economic crisis, social crisis for some countries, also at political level, with catastrophic effects. It is in this context that the pandemic also provided with an opportunity. In the public policies discussions, health were always the first line of discussion, and this allowed to access more resources of the public health systems in the region. Information is showing that between 2015 and 2019, as an average in Latin America and the Caribbean, the data from central governments are expressing that the expenditure was 2.2 of the GDP, and in 2020, it took a leap to 2.8, and 21, 2.9. Therefore, the pandemic did bring together with it more resources for health. But what happens in post-pandemic periods, what happens in post-pandemic is that the public discussion, health is not in the first line of discussion. There is a tremendous challenge right there in designing public health policies to be able to consider how important health is, of course, not only for the population, but the right of health, the strategies of development, the importance that it has in terms of growth, and certainly enough, the strategy to be able to approach inequality in the region. And the second element is, again, I would like to thank the participation of all the authorities here in this seminar, either virtually or right here in the room, and to thank the possibility to have this area to be able to discuss and how to move to universal health, considering the different realities that the different countries are going through. It will be very rich to get to understand the different challenges that the countries in the region are going through in strengthening international cooperation, and also the different exchanges that certainly will occur in this seminar, this international health seminar. Thank you very much.
Muchas gracias, Alberto, por
Thank you very much, Alberto, for your opening words. Before starting with a panel where we will have the words of the different authorities of the country that are part of the area of development of the United Nations, I would like to mention that in Zoom we have interpretation into English and sign language if you require it. To start with this panel where we have the different authorities from the countries participating in this uh, development area, we would like to offer the floor to Dr. Edward Montour, Vice Minister of Primary Health Care of the Ministry of Public Health and Social Assistance of Guatemala, and we want to thank him for being here today. If you can please share his presentation, thank you very much. Good morning. It is a pleasure being here today, sharing the lessons learned, but above all, that change to the transformation of health system. The pandemic is a very important point where even though we have tremendous gaps in the national health systems, we identify opportunities, and it is the opportunity to take into practice the different approaches that are all operational, that was required by the pandemic at some point, and thus provide a response and not allow for deaths in the region. It has meant that the population was able to identify the importance of public health in the health systems. It was acknowledged this public health issue for the population. Given the tremendous expenditures that people had to go through when they were participating in the public system or because of their insurance, we would like to share with you the lessons learned of our country, such as primary health care. It is a tool for advancing access and coverage in health and experiences to overcome inequality. And we will specifically be talking about the case of Guatemala. We have challenges, but also we have opportunities. The lack of resources, fragmented services, a quality of services that should be improved. Access to services is quite limited. Our universal coverage index, according to World Bank, is 59%. And the pandemic allowed us to hold a political commitment and support to primary health care. Start with reforms to increase the budget, to strengthen the systems that are the existing management system, to be able to improve the different sectors in improving coverage at universal in universal areas, and the strategic alliances with Social Security. And a part of this, we were able to identify new threats during the pandemic. Also, climate change was affecting us. We had tropical storms and hurricanes, meaning that we need to consider in these planning exercises those vulnerability factors that are important, as well as the exposure means and how to strengthen the health systems through leadership and governance. to strengthen the staff in the area of health, the information systems, equipments, new technologies, differentiated care, novel systems. But something that is very important is funding. The stressful elements is how, or the factors is how this is affecting us, as we have secondary crises as well that are due to climate change. We have nutritional crisis. It is affecting us in the area of agriculture, of human health. And we would like right now to be able to consider the approach in a crisis. When we are talking about the response from health, an operational aspect that is very practical can be an approach from the perspective of the demand for care, epidemiological factors, our population pyramid. The way it is created is to be able to identify who is going to do what in the population, who will be the affected ones. The pandemic showed us that the elderly were more vulnerable, but from the perspective of offer, to be able to identify our installed capacity and thus identify a gap that establishes different services, meaning that we became quite operational in the approach of promotion, prevention, services of care and rehabilitation, as well as not forgetting universal access. The changes in health determinants, the social determinants, the health systems that are weak or with an imperative need of becoming new areas. All this means new challenges to the health systems. These health systems have a need to transform, to adapt, and provide responses and guarantee universal access to the population. So it is here where we consider the other focus or approach, and that is the public health essential activity. Even though this sounds quite theoretical, it is very important, as these essential activities of public health are considering the importance of assessment of all of our interventions. This requires public policies that will guarantee universal access and will allow for the participation and social organization. As well, it needs access to the for the population to basic services and specific intervention and funding, and be able to comply with the 30-30-30 plan. That is the main challenge that we have currently, as in our country it increased 6 points of the GDP in health investment, to be able to decrease that expenditure, the out-of-pocket expenditure, which will take us to certain aspects, which is the principles and values that have to guide all of the health systems to guarantee access.
El enfoque intercultural, la atención primaria.
Primary care that is focused in the population but not in the problem is what is needed. And this is what we have been involved in, and it is part of the transformation. And we are open to comments. Thank you very much.
Muchas gracias, doctor Montoro.
Thank you, Dr. Mantufer, for your words. And of course, in panel 2, we will hear your presentation, and certainly enough, we will be able to delve into all of the topics that he considered in a general fashion. And now I would like to offer the floor to Dr. Salgado, Undersecretary of the Ministry of Health in Chile. Thank you very much for being here with us.
Buenos días a todos. Muchas gracias a la CEPAL por la
Good morning, everyone. Thank you, ECLAC, for the invitation to the ministry. Unfortunately, the minister was unable to make it. I bring her message of thanks and greetings to the participants here in this room and outside virtually. I will present what today is a proposal of reform for the Chilean health system. And as it has been already said, how can I do it? Yes. Now, it is about the reason for the invitation, and that is inequality in health that affects most of the countries of Latin America. Chile is no exception on that. To show only one of the aspects where we can find inequity and where the population has become aware of this reality, which goes long back. And there we showed a survey insofar as the concern of our population about inequality in health. In different years, we've seen how it has grown. Some signals of this: 18% of Chileans live with 5 or more chronic conditions. Non-communicable chronic diseases are a true epidemic in our country. But infant mortality is twice as much, though in Chile it's quite low as an average, but averages hide different realities. And in terms of mortality in the poorest sectors of Chile, is twice as high as that of better off districts. Diabetes is 3.3 times more prevalent in those people with less schooling, and therefore there are two Chiles. Chile is this long strip of land, but in fact these are two Chiles. We have a true epidemic of overweight, particularly in children. Mental health, it is a problem, a serious problem. Mouth or buccal health, and to all these health problems, there is inequity. And that provides a political dimension. At some point, Chile suffered the social unrest, where the basis for that was inequity in different aspects, not only in health. And there is a demand of our society. There is an exacerbation of the epidemiological profile. We have a segmented, fragmented system, and the pandemic revealed, evidenced these deficits with a greater dimension. Now, the response that the government of President Boric presents is precisely a reform. A week ago, surveys showed that the population of Chile raises a reform as a need, reform in health. This reform has some principles: universality, solidarity, freedom, justice, trust, quality in the system, social participation, deep one. And 3 or 4 axes for transformations are raised. First is to modernize the public system and make it decent in Chile. Second, guarantee universal coverage of primary health care. 3, generate conditions of healthy life with equity and build a new system of social security and health. The first axis: Chile has a public
system of geographic coverage that is quite significant. It covers 80% of the population with deep flaws. We work in networks, however, they have problems. We hope to solve those problems and see to the quality of care. The introduction of the digital medicine in the sector, there are also deficits. Hopefully, we will solve them. Human and decent treatment with sufficient resources and the concept of resilience for the system to be able to respond to the different emergencies and disasters we suffer. We have a fragmented system, and we want to move to one of universal health or primary health care. The fragmentation occurs in the whole population in groups of persons, levels of care, and territories. And we want to move to access for persons and communities with participation of these communities in healthcare to be territorial, close, person-centered, or centered also in families with networks and with the community network system or concept. How do we plan to change to a universal primary health care with the close access, effectiveness, quality, with equity, and have universal primary health care, and to have their population with a co-construction of health with society, with sufficient financing, with adequate resources, and so forth. The third axis, that is one of equity, basically referring to the social determinants. This is from 2002. That is the graph where health problems have much more to do with the economic and social environment. And you have the imperative need of facing this social environment. The way how we want to face this is with social participation, intersectoral work in the territory. Members need to have a legal framework for that, but at the territory level, there could be different instruments and trying to integrate social and health care with a strengthening of the monitoring and assessing capacity of this within the local environment, producing or bringing about changes in programs, assigning social value to the different interventions, and with committed local governments that will give room to health innovation. And social security system, well, we have structural problems in our social security. We have financing segmentation. There's a public and private world that fragments the service provision. And then finally, there is a major dependence on capacity of payment to solve problems in the population. And it has worsened with a catastrophic spending pre and post pandemic. In that aspect, the government has moved towards a universal health fund. That is our target. The out-of-pocket expenditure has been reduced. That's an important thing. The co-payment was implemented in the public sector. Persons had to co-pay or pay their care, a group of them, and that has been deleted. So co-payment is zero. Or out-of-pocket payment. One same price is for public and private services. You have the modality of replacing these insurances for one of supplementary coverage in FONASA, which is the public fund, and voluntary insurance and supplementary insurance. And we speak about universal APS or health, primary health care, where social security would be the major framework. This primary health, it would be the heart, this would be the first tier of care, but also coordinating and working the different social determinants at local level. This second axis that we will go into details starts with the declaration that we share, and that is primary health care strategy in public health is key because it's more efficient, effectiveness with greater efficacy and has better results on the quality of life of persons. We hope to move from PHC, which is restricted, to those registered in FONASA public funds and that have been registered in some primary health uh, center or system, and to move towards a system of universal coverage guarantee. All the persons of the territory, regardless their health insurance or payment capacity, will be integrated in all these services of care, promotion, and prevention with strategies addressing the territory completely with a major preventive component. Now, the assumptions of this axis is that PHC should be the main strategy for the healthcare of population and an articulator of the whole system. This strategy needs to be built based on integrality, access, availability of resources to be acceptable by the population with quality and security. And the concept is that this is the task of all and not only of the health system, and acknowledges the historical development of primary healthcare in Chile. This in Chile is not a minimum care. The whole portfolio of services is quite broad with a multi-professional team, and we plan to underscore these unique aspects, but we plan to reach universality. We have guiding principles like coverage, governance, adequate financing, appropriate for the model, intersectoral work, and with sufficient resources. This line it has three strategic points: expansion of coverage and access, uh, integral comprehensive care model, both in the health, social, and environmental aspects, and with optimized resources for their good performance. The first line, which is expansion of coverage, we start by universal registration. Not all the persons of a territory have been registered in the health center. Hopefully, the totality of the population will. To favor effective contact, either because we improve the availability of care hours or schedule changes of different hours for the staff, generation of platforms of digital agendas for appointments, the expansion of time for care, also expanding or broadening access, adapting infrastructure, mobile devices, telemedicine, and the concept of resilience through the different competencies of the staff in order to face these emergencies. Strategy number two, that is one of care, integral care, social, environmental, and health. There is a strategy underway, and hopefully we will disseminate, and it's called SECEP, Integral Care, Person-Centered. Traditionally, chronic problems are are addressed by programs, diabetes, hypertension, and so forth, and they're vertical. This strategy seeks multi-modality, but more comprehensively and person-centered. With the continuity of care, we hope to have new health governance. The network governance is very much centered in hospitals, defining the role of specialists in primary care, improve better experience of citizens, and improving the user experience with the labor force with appropriate capacities and capacity building. Number three, Third, a strategic line that is optimizing resources, performance evaluation, considering the availability of resources and ongoing assessment. This strategy considers efficient expenditure in resources with quality and decent resources as to staff, with information and necessary data, data governance in the system, and that will allow for better decision making with more detailed and timely information. And then finally, a framework for monitoring designed for improving performance. This strategy is underway with a progressive implementation. Today, there is a pilot model within the present regulatory framework. It hasn't been changed. And in this first stage, we consider 7 districts with different elements: population, rural aspects, political variation, different political colors of authorities involved in these pilot districts, where we plan to expand the availability of services, improve registration, but a pilot is underway, which is going to be monitored strictly based on all of its concepts in such a way that before the end of the year, we may evaluate what are the strategies that have resulted, what are the legal, what is the legal framework, so that we may expand from 7 to a higher number of districts within this universal primary health care.
So I took also this picture of Bernardo Bectorel, who is in charge of this reform at the Department of Health, in order to reflect upon what is the concept that we have for the development of civilization. And you can see the drawing on the right-hand side that is standing and upright and looking ahead. And we think that we should change this idea towards the people who are not better fit to be standing, and the people who are around them should be able to raise him. And that's what we have prepared. Thank you. Thank you, Dr. Salgado, for this presentation, as well for your words. It's very interesting to see the different axes of this reform. Obviously, we will have a full presentation that will deepen into some of the specificalities. Later on, we'll see a video of Dr. Asal Cristina Laurel, who is the director of strategic planning for the Mexican Institute of Social Security, IMSS. And for reasons of a schedule, she was not able to be present here, but she shared with us a video. The pandemic, in my opinion, was revealing the fragility of most of the health systems in the region. Based on this, we do not want them to be resilient as to let them go back to their previous condition. But we expect them rather that they are seeking to be more innovative health systems, allowing to overcome the limitations confirmed during the pandemic. And it also seems to me that what we wanted to have is a system allowing to foresee more in advance the major health issues. Because although many had been talking about the possibility of a pandemic, nobody had taken it seriously in terms of its spreading. I think we all agree that we want universal coverage. However, We should specify what kind of coverage and the mechanisms required, since we have been discussing at least for 1 or 2 decades about universality, and they have very different contents and different contexts. Then, one of the sizable tasks is to develop a strategy to desegment the public system, to revise the policy of service packages that have been very varied in different countries, and sometimes they are really minimum packages, as recommended by the World Bank 3 decades ago. Anyhow, what we have to do is building the pathway to escalation, that is, working on how we are going to increasingly include more services, both preventive and promotion services, as well as direct the provision of medical services. It is also necessary to estimate costs and sources of new income and expenditures, and this is closely related to tax issues that have been under discussion in Latin America, for which exists a series of stances on how increasing the state revenues and how quickly taxes are raised and to whom. In other words, the fiscal issues can be tackled in different manners, and it would be worthwhile making it clear how this issue is being approached, because otherwise there could be major setbacks. In Mexico, we have opted for the federalization of state health services with free services and medicines, and all of these run by the decentralized public organization called IMSS Bienestar. This federalization scheme is voluntary. That is to say, the federated states themselves decide whether they would like to adhere or not. It has its own model of care, which includes organized people's participation in view of not setting up health committees supporting. Not only that, setting these committees supporting the service delivery units, but they should also actively participate in deciding how the services are to be provided, how to challenge poorly provided services, and so on. For those states that decide they are going to participate in this process, they will receive an injection of resources to restore and dignify the health care units. This is considered absolutely necessary because whenever a precise diagnosis of the healthcare unit's status has been conducted, it has been found that we have infrastructure problems as well as personnel problems, and at the same time, problems to what hours related to the hours they are open and whether they have the capacity to refer patients elsewhere. And what is very important, how the healthcare systems are organized for the promotion, education, and prevention in health services. This is just one part of the increase in spending that can be relatively punctual, although it should be clear that we have to support the initiatives to restore and dignify the units. But we should obviously also come up with, as we are going to present from Mexico, that is to say, the calculation of the resources required for operating expenses. This makes a lot of sense because it is the basis on which we can calculate how we can progressively increase the service delivery and how we can then equate the real financing and the provision of such services. We are convinced that this journey is not a short one, but we are certainly aware that we have enough elements to develop this strategy for escalation and that we will also be certain how much it is going to cost to the government, which is the only funder of these services. I believe that this is a good introduction to what actually Raciel is going to present in his presentation on how we have done, how we have thought about the costing of services. Thank you very much and good luck in this meeting. Goodbye. We would like to thank Dr. Laurel for this video as well for the important messages that have been pronounced regarding the reform that is underway in Mexico. And to close this panel, I would like to thank over 300 people who are connected through Zoom. Obviously, I would like to acknowledge the presence of our authorities in this panel of discussion. I would like to thank Dr. Salgado, and we understand that you have to leave us now, and we'll go into the next panel. Thank you, everyone.
Buenos días.
Good morning, everyone. And we will continue these first panels, the main challenges of the healthcare systems in order to move forward to this universality approach and the obstacle in the access within this right-based approach. The objective is to discuss about the main obstacles encountered along the way to guarantee this access to health care. First of all, we will have a presentation that we will illustrate us on the main topic, that is to say, the inequalities existing in the region. And later on, will share, or they will share with us, the experiences from the different countries participating in these projects. So, with no further ado, I will give the floor now to Maria Luisa Mariño once again, who was the moderator, and she will make the presentation about health and inequality in Latin America and the Caribbean, the centrality for these sustainable development scheme. First of all, I would like to greet the panelists who are with me in this space, Mr. Ramirez, who is with us today, Vice Minister of Public Health of Colombia, who is connected online now, and Anne Sucata from the French Development Agency. Thank you very much for being with us in this space. I will first share the presentation with you. Just a minute, please. So you are already sharing the presentation. So throughout the presentation that I will make today is part of a publication that we're now developing. The Division of Social Development with Alberto Mérez de Mesa Nahual. And this presentation or publication will be available by mid-October, and you will be able to see further details of what we are going to present today. This is within the development account of the United Nations. That is the context for the seminar today, and it has as a core piece the inequality and how to move towards the social and inclusive development. And the main messages that are included in this document and in the presentation today are the messages that are part of the framework of the seminar that we are participating in today. First of all, we have the centrality of healthcare in order to move to the sustainable development. As we saw very clearly during the pandemic, health is paramount importance in order to have all the dimensions of the economic and inclusive development and the environmental sustainability. When we see the progress that has been gained by the health of the inhabitants of Latin America and the Caribbean, we see that there is a situation of profound inequalities. We see the direct effect of these effects of the social determinants that at the same time are determined by the access of the social matrix, as it was said before by the director of the Social Development Division. And precisely within this interaction existing between the different determinants, social determinants, and the accesses, we have this situation.
Que queremos destacar en esta presentación es la importancia que
We want to highlight the importance of the connection between the health systems and other components of social protection, since this connection is a contribution for the epidemiological indicators and health issues, as well as to reduce the inequalities in the region and move towards inclusive social and sustainable social development. And together with this connection, as we heard at the start, the health systems in Latin America and the Caribbean have structural issues that we need to address and strengthen decisively in relation to or making the most of the window opportunity opened by the pandemic, and that now we must pick up and not forget. And lastly, in this sense, we speak of the need to move ahead urgently with these reforms towards systems that are universal, that are integral, sustainable, and resilient, and with a PHC at the center. So to begin, let's see the central role of health in sustainable development. Health is at the heart of any development model. As we saw during the pandemic, we need to ensure the health of the population for society to work in its various dimensions, considering health as the total state of physical and mental health. To address the integrality of health. And so we realize that without health, sustainable development is not possible. This was very clearly reflected in the impact of the pandemic on the 2030 Agenda, that is, the impact of health on the 17 SDGs. And since we saw a 27% lag in the achievement of these SDGs, on account of the pandemic, that clearly shows the interdependence between the rights to health and other rights of the population. So we see that health is in fact not only essential to development, but is also an essential tool to combat inequality, and as such, access and universal health coverage can help reduce inequalities in health, but not only health, but also a reduction of the social inequalities created and reproduced via health inequalities. And so, investing in health is also investing in strategies to help overcome the difficulties and move towards sustainable development. And here we have a short summary, and I say short because in the document as such, it is far more elaborated. But what is the role played in this in sustainable development? Health, on sustainable and inclusive health, and impact on that allows you to reduce the risk of falling into poverty, and healthy population has better performance in education, and so different impacts of how health contributes to inclusive social development. But not only inclusive social development, but economic social development. And healthy people have better economic outcomes, have a positive impact on productivity, and this too was something that we saw very crudely during the COVID-19 pandemic and the historical setback undergone in terms of GDP in the region and worldwide. And not only health, but health inequalities have a negative impact on the economy. So what we're saying is that health is not only a right that must be ensured for the population, and as such, it is an ethical imperative, but also it is necessary for the economic efficiency of society. And lastly, health policies do have a positive impact on environmental sustainability. We see that policies such as promoting physical activity or sustainable mobility that contribute to reduce the levels of contamination at society level. Having understood the centrality of health, we see how the health status is in Latin America and the Caribbean population strongly marked by inequality. And what we're showing in the document is that, on the one hand, in fact, key epidemiological indicators such as life expectancy or child and mortality rates and maternal mortality rates have significantly dropped in recent years. But when we see this among countries, we see that within each country, it hides deep inequalities. For example, child mortality rates, which in itself is quite good regional level, but when we look at this by country, we can see differences that are more than 5 times among countries in one same region. And so the call is to highlight the inequalities marking the progress of health in the region. And the explanation that these inequalities have are essential to understand how they should be addressed and combated. And in this way, well, in our analysis, we highlight, as was already presented by the previous speakers, the role of the health social determinants of health that have to do with the conditions that people live in, how they're born, and how they work, how they live, how this is with them throughout their life, and this has a negative impact. And these social determinants of health are unequally distributed in society. And that is the heart of the issue. Some groups accumulate worse health conditions. They have a worse distribution of the social determinants of health, and this means that they have worse health conditions, with the impact that this has on other dimensions of their overall life. And this unequal distribution is conditioned by the structural axes of the social inequality matrix: the economy, social class, gender, the stage in life of people. And these are some of the examples that affect these unequal health outcomes. And just to give you an example, we see how informality and schooling, poverty and extreme poverty do in fact have a negative impact on the health of the population and lead to inequalities. This graph that we are showing shows how infant mortality rates are high in countries with a higher degree of informality, of labor informality. But we know that within those countries, labor informality is more common among women, young people, migrants, and persons with disability. So this is a condition that in fact is unequally distributed and leads to higher child mortality rates. And here is where we highlight the role of PHC and its relevance in terms of closely and positively connecting between PHC and social protection to not only achieve better health outcomes, but also address and reduce inequality in the region. And here we see how, on the one hand, social protection has a direct impact on the unequal distribution of the social determinants of health through, for example, measures such as paid medical leave, cash transfers, pension systems, an endless number of tools that contribute to level the distribution of these social determinants of health, and in turn, PHC that considers all this and includes actions to help prevent inequality and poverty, such as nutrition programs, financial protection to reduce out-of-pocket payments, and all of these are actions that allow reducing the reducing inequality in general, not just health. So the connection between these two dimensions are essential in order to overcome our inequality issues. And at the same time, we need to address the structural weaknesses that our health systems have, and also mentioned in the previous panel, the health systems in the region have suffer from chronic underfinancing and accompanied by a very high level of out-of-pocket spending. And so, public system, no more than 4.4% of GDP on average, with a high level of heterogeneity among the countries of the region, only 4 of the 33 in Latin America and the Caribbean exceed or achieve 6% of GDP. And this, of course, translates into a shortage of inputs, a shortage of infrastructure, which is essential for the operation of these health systems. And just to give you an example, we include the shortage of physicians per 10,000 inhabitants, but this shortage is repeated in other dimensions that are also essential to ensure the right people to access health services. And so this is accompanied by a very high level of out-of-pocket spending. A third of all health spending is equivalent to 2.5% of GDP in the region. These are out-of-pocket spending. This has to do with financial disprotection. And so people spend about a tenth of their income on health, 1.6 up to 25% of their income in health. Now, this sort of situation hinders universal health and contributes to maintaining the vicious circle between health issues and the rising health expenditure and the lack of protection that this entails. And together with this, we have health systems that are segmented, fragmented, health systems that work as parallel subsystems without any solidarity among subsystems, and they divide the population up based on their ability to pay and not their needs. And this, of course, multiplies inequalities in terms of health and other dimensions. This is accompanied by fragmented systems in the provision of these health services, reflected in lack of coordination among various health levels, lack of continuity of care, which is crucial in societies such as ours, where non-communicable diseases represent a high degree of the burden comorbidity. And this, of course, is ultimately reflected in the lack of integrated networks and all the inefficiencies that this entails. And in turn, this is related to a concentration in curing and not preventing, together with a first level of care that is precarious and uncoordinated with other levels. And on many occasions, there are low levels of financing. And so therefore, in this scenario, when we know that the centrality of health, not only because the population has a right to health, but also in order to achieve sustainable development, if bearing in mind that we're in one of the most unequal regions in the world, we are calling to address the inequalities and move towards health systems that are integral, sustainable, and focused on PHCs. Universal systems are characterized by having universal access and services, and that depends not on the ability to pay, but the needs of people. And legal and effective coverage is the same. Access is equal to coverage. Integral systems that are able to respond to the various needs of the population, but that can also connect to the other sectors and public policies that are very much integrated, as we were saying here, to other components of social protection, the education system, the labor market, that is, to address health comprehensively as we have defined here. That the system be sustainable, that is, that they're able to meet coverage, quality, and sufficiency of the benefits and guarantee this to all generations, and must also be resilient. This is something that Dr. Mantutre mentioned. That is, the ability to adapt to changes and crises, and also be able to face crises without this meaning an interruption of the health services, as did not happen during the COVID-19 pandemic. And to move ahead and on these lines, and in fact, be able to consolidate or strengthen the health systems, we speak of the need to implement reforms that, in fact, in different countries of the region are already undergoing, and identify the various dimensions present in the reform.
Por supuesto. Of course, this reform to health systems has a technical dimension that mentions the model of health that we would like to head to. But together with this dimension, there are other dimensions that are important to consider, which are the financial one mentioned by Dr. Laurel in her presentation. And Raciel will also be talking about that dimension, but it is fundamental to consider the cost analysis and the sustainability of the funds as it is being expressed. The institutional dimension is the different elements of the health institutionality. These are one of the main elements that will be conditioning the success of the reform in health. And we have elements such as the regulatory aspects, the presence of technology and of information that has to be considered when designing these reforms to health. And of course, the political dimension. Health is an area that is really marked by economic and social policies that have to be considered in designing the reform. And finally, the dimension of communications, this public narrative that is considered for the reform. We have identified this as one of the elements that can or might condition the approval of these reforms as well as its implementation. And it is in this idea and the call to strengthen the health systems, we again would like to emphasize the primary healthcare systems, PHC, to reduce inequalities in health and in other dimensions, as we previously mentioned as well. What we are seeing here is that during the pandemic, those countries that had a very strong institutionality in PHC, that had a very robust PHC, had a better response and faster response to the impacts of COVID-19. Nonetheless, what we are able to see that even though some countries of the region are considering 30% of their public expenditure in the PHC for the PAC 30-30-30 of PAHO, when the total expenditure in health is very low, lower than the 6% recommended by the WHO, this tends to be a very low per capita expenditure to be able to consider the needs of the population and become a PHC that is able to solve issues. The idea is to be able to invest in PHC as it is a strategic aspect, not only because of what we considered in inequality and its impact, but also because it considers widening coverage, which becomes much faster. And here we're specifically talking as a strategy in terms of PHC, but also the investment at the first levels of investment of health, allowing the possibility to reach much faster to those extreme areas, geographical areas, generating consensus in the need of strengthening this level of care. And it also has a very important fiscal magnitude that it is easier to establish. We consider PHC as a strategic tool to be able to move forward in the social inclusive development and sustainable. And I would like to just take a couple of minutes to be able to close this presentation and emphasize the call to really take an opportunity of this window that the pandemic provided. In post-pandemic, as the director of social development was mentioning, we have to make an effort for health to be in the center. Health is not in the center of the discussion every time that the pandemic has been overcome, and we have to remember and emphasize that health has to be considered in all of the strategic elements in terms of development, not only in the impact of health, but also to be able to visualize this impact and be able to move forward in the other dimensions that are part of sustainable development, and thus be able to move forward in comprehensive health policies that are related strictly with the social protection systems that allow to reduce poverty, reduce inequalities, and overcome structural obstacles that will not allow us to move forward into the sustainable development elements. Together with these policies that hold these characteristics, there's a need for strengthening the health systems to guarantee access and universal coverage, together with more linkage with other sectors, so that universal coverage and the care can be sustained throughout time, and also the possibility to respond to crisis and be able to work ahead of time before crisis and future pandemics. And thus, we need to remember the importance of the different dimensions involved in the reform in such a way that the discussion that is carried out on how to strengthen the health systems, as well as how to approach the consequences of the pandemic, not only to be prepared for future pandemics, but we still have challenges that we need to respond to, and that they become successful and last throughout time. Thank you very much. Thank you, Maria Luisa. It is not because she's from my division, but this has been a very interesting presentation and, well, wonderful study that you have carried out. It is key for me, all of the analysis that was carried out, of course, it was previously shown, but you will be able to read it in October in terms of the impact of health, not only in health, but the economic and social development as well as sustainable development. As a matter of fact, I was remembering while you were presenting of a study that we carried out at ICLAD here together with Rodrigo, Andres Fernandez, and Mr. Martinez. I was able to participate in the cost of malnutrition. We were showing that between 4.7% and 6.3, if I am not mistaken, of the GDP, it means that there is a loss of productivity in terms of the cost of malnutrition. I think it is very important, even though it is an ethical element to be able to invest in health, we have to highlight these additional impacts of the additional impact of not doing it. Nonetheless, inequalities is a relevant element in the region being one of the regions with more inequalities, to maintain these structural inequalities that are affecting the health systems, it is very important to be able to move forward and generate mechanisms to reduce the gaps. We saw that they increased during the pandemic, undoubtedly. The fact that we were all in lockdown, the access to health that was limited given this lockdown affected health, and the population that was very vulnerable, probably, for example, that did not have access to telemedicine or other services that could have been provided through different means, and the articulation between social protection and primary health care. The last thing that she was presenting, Maria Luisa, is this linkage with the social sector, thinking about the social determinants, not only in health, but in general terms of well-being. There has to be a linkage between all the sectors to be able to move forward. Health is impacting children's education, and education is impacting in something that we have been hearing, which is self-care, helping in prevention. So this is so important with between the different sectors. When I am enjoying, I tend to take the word while being a moderator, but I should not be doing it. I will have the presentation of Mr. Raciel Ramirez sitting right by my side. He is feeling this cold here that we have. He's coming from Mexico, from the Division of Innovation and Financing Models for the institutional transformation of the Mexican Social Security Institute. We would like to thank the Vice Minister of Public Health, Ministry of Health and Social Protection of Colombia, Mr. Jaime Urrego. He is with us virtually, and the Director of Health and Social Protection of the French Agency of Development, Agnès Soukat. She is also virtually with us. To start with the comments, I would like to offer the floor to Mr. Raciel Ramirez. You have been acknowledged. Good morning. Well, thank you very much for this time provided to the IMSS, especially this year that we are celebrating 80 years since its creation, and it has been providing social security to the population, and currently it is for the opening to all of the population with the organizations of public, decentralized public organizations. And with Dr. Laurel, she wants to thank you all for this technical cooperation that we have been carrying out for more than a year and 7 months approximately. And the Institute has been proposing a methodology that has generated a validation, and we have generated a response to this methodology adopted to the system of these OPD IMSS Bienestar in this methodology that is important for the needs that you all believe we have. Starting from November 2019, the Parliament reformed Article 4 of our Constitution to be able to consider the obligation of the state to provide the vulnerable population, in this case, a population that does not have Social Security, the national health system for well-being. Additionally, it was presented a national social protection commission in health, especially this popular insurance. And this is the central element of the health system. Specifically, it was the total, or the three dimensions of universality. And what am I mentioning here? It is coverage, providing services, and the financial regime. The total coverage was open to the population, and to be able to establish a survey and provide services, coverage of services that is very well known as Seguro Popular, or the People's Insurance, if the people were not within the catalog that could be provided, the people would not receive the coverage. And that was already eliminated. And there's open coverage to be able to provide services according to the needs of the population and the financial regime, which is what we will be talking about in this methodology, and thus determine which are the necessary resources that each of the entities need at federal level to provide services and what each one of them are receiving. In January 2020, there was a new Institute of Health for Well-being called INSABI, and it did not cover with all the expectations of what was needed, and it had to be extinguished. And by August 2022, there is a decentralized public organization called IMSS Bienestar to be able to provide this care and to the system that this program is providing, not as a decentralized organization, but rather it is providing services for more than 40 years. Given the strength of this project, it was established as a provision of medical care and medicine for the population that does not have social protection. When including this organized this public organization, decentralized organization, means that there is a federalization that provides services and thus determines social services for the population that does not have a normal income. To be able to consider this, we needed to see the infrastructure, the health staff, the medication, and the regularization of the staff. There were certain areas where the entities would need to be part of this federalization. They had to be free. Any entity can or not be included in this federalization. And the incorporation of the health staff is on a voluntary basis. There is no obligation to participate in, and the transfer process of this federalization had to be a non-interrupted services.
When this transition began, structural change in the system, we had to ask, how would we generate a cost for health services of open population? What methodology would have to be applied in order to determine the cost? What was the population without Social Security in Mexico? What's the cost of services involved in investment? Now, the extinction of services provided by OPD, IMSS are the same one of the health systems. The management cost of these services was covered with the cost that we have determined. These were the main factors that we challenged in order to determine this type of methodology. So we did a methodology by layers, where you have the tiers of services derived from the levels of each one of the entities. Of course, we had to do a separation of population between rural and urban, because the program as such, IMSS Bienestar, is mainly focused in the rural area. So we had to de-link or separate both populations in order to determine how the service is being provided, rural and urban. And the access to service needs to be ambulatory or hospital service or hospital stay service. There were assumptions that we defined in order to implement the methodology. The totality of services, for that, the regular IMSS was taken with the coverage of all the services of Mexico. We didn't have to look for a medical service of or health service of another country to be adopted there, but rather we accepted the information of the same institute in order to take the totality of services provided. Does not include the investment cost in infrastructure or equipment or fixed assets. There are services only. We are quantitating health services, drugs, and all. the calculation of cost does not take into account current or labor liabilities of the Secretariat of Health. Only the care, ambulatory, and hospital services are included. As to information of costs, because of the pandemic, the data corresponding to 2019 were taken, and an update was made in accordance with the CPI for May 2022. This methodology has been worked for 2 years, so we need to do a true update, but we are preparing the amounts with these figures. Now, the estimate of the cost of the baseline scenario, which is the use of services, was taken in accordance with the characteristics and infrastructure of each one of the service provider entities, and therefore having its the cost of the baseline scenario was generated. So we had one objective: establish a methodology that will serve to estimate the cost of universality of health services, medical care, free drugs for the population without social security, to the subgroups, establishing a cost range that will determine the gap of necessary resources for providing services. We defined a top limit, the ceiling, that is, that will quantitate the total cost of the regular system of IMSS. We have a ceiling scenario and a lower limit in order to have a floor base that will estimate the incidence of the use of health services reported by the analysis department. There will be entities where they will not be included. We won't generate that in the implementation of the methodology. Once the gaps have been defined, then input. Where do we get these input in order to evaluate? The open population was considered according to the population and household census, and that is a population affiliated to INSABI, IMSS Bienestar. The size of locality was taken into account to know what's rural, urban, and divided by sex and age. Population with poverty and with population with extreme poverty, two sectors, because we didn't know what population was to be considered. So we tried to divide this into three populations: open population, population with poverty, and with extreme poverty. And in accordance with the methodology, the open one is that has multidimensional poverty, or with the line below the poverty line, or has one social deficit with the same division by locality and by age. Population in extreme poverty is the one that is below the poverty line and has at least three social deficits with the same structure. As to productivity, we went strictly to family medicine, odontological, and emergencies. So this information was taken for a 4-year analysis, 2017 to 2020. Why did we consider this period of time? Because we wanted to know how the population behaved before, during, and after the pandemic, so as to see the provision of services in consultations, and same thing for hospital discharges. This was analyzed with this diagnosis so as to know hospital discharges, size of locality, division of population by sex and age, And this information was analyzed in accordance with the General Information Service of Federal Health Secretariat, where you have each unit and productivity of services of each entity. Now, the strengths of the Institute to generate this methodology are for ambulatory services based on activities. The finance division obtained or determined the per capita annual cost of adjusted by sex and age. This cost does not include the operation costs or retirement or pension systems. We know that the Institute is one that provides not only health care services, but social security as well. And the additional costs were not included in this one. And we are only considering now the expenditure in health. So the same cost methodology was used, but this was included in services. What will the cost be of services of family medicine, odontology, emergency, in order to determine the gap of the baseline methodology from 2017 to 2019? And for hospital stays or discharge, the medical service group implemented a methodology of groups related to diagnosis so as to know the relative weight of each one of the federal entities of the analysis. This is what we used of methodology to calculate the cost of the financing ceiling. We are considering the population depending on rural or urban, man or woman, and according to age, to be multiplied by the per capita spending. These are the costs of per capita operational medical expenditure of the Institute. It's already in dollars, so as to do it to have, so you can have your own exchange rates. Per capita medical cost of an average man is $292. For a woman is $300. Maximum spending of men is $1,104, of women $923. And then standard deviation 206 of men and 155 of women. What does this expenditure include? It considers 1.8 consultations of primary level, 0.6 consultation of second and tertiary levels, and hospital expenditure of 4.3% of the population. Those are included in that expenditure. Now, as to the calculation of the financing floor cost, we had to do some services equivalence in order to consider each one of the parts that we were contemplated for ambulatory services. Family medicine, first time or subsequent ones. Continuous medical care, which is in the areas of emergency, quality, not qualified, and general medical care. Odontological consultations were the same ones. Consultations of specialties in the second and third tiers was the only thing that was contemplated, and also emergencies, depending on if it was a second or third tier. Once we had specified this service equivalence, we wanted to cost by levels or tiers of care. And so the first, second, and third tiers were quantitative for each one of the areas, rural or urban. If a population or an entity has no services in second and third tiers in rural areas, only the first ambulatory tier was contemplated. If in the rural areas hospital was not included, then diagnosis or care or group care in hospitals was not considered. And GRD, what's that? That is population that the federal entities did not provide services and they migrate to another federal state to receive hospital care. We were able to quantitate and determine costs there. Based on that, we have ambulatory medical services. What's the cost of IMSS services at first, second, or third tier, depending on general consultations? Average for men, it's already in dollars, $43 for men. In average for women, 44. The cost of services in the second tier, 66 men, 65 women. Third tier in men, the cost is 135, and for women, $132. In second and third tier, men are more expensive in average than women. And in the first tier, we have a minimum difference, but women there are a bit more expensive. Once we generated the groups related to diagnosis, the Institute has 729 groups that the relative weight is 17.59 to 2.58. The cost would be $2,600 approx. And they're grouped by all the descriptions of diseases these are 25 groups and two of major diagnosis in order to know how much was in hospital expenses. We generated two gaps, two costs. Gap number one considers the ceiling cost plus management or administration admin costs. Those are additional admin expenditure, which are of the IMSB Bienestar program minus the state and federal resources provided by each entity. Gap number two, which is the medical floor cost, admin costs, and federal minus federal and state resources. Then the structures of the population, and that is how population epidemiologically, how is it integrated and calculation of cost. National total population, we have 53.1% without social security and 47% without affiliation.
Here I presented two entities. In here we have Veracruz example, and we see some inequalities. There is more protection in this region compared to Nayarit, and they have some kind of affiliation. Obviously, we have here the structure of the population without this social security. We have these numbers that are very high without a social security scheme. For the prevalence of conditions, health conditions, uh, see that everybody undergoes the same things. We have diabetes, hypertension, and high blood pressure problems, and we see that this is below the national median, but not in the case of obesity. And we have the same circumstances, overweight in the population, the whole population in Nayarit and Veracruz, as compared to the national value. For now, the national care for services, we can see this as compared to the general health problems in the population. The population is seeking for care at the national level, and then in the federal schemes, and over 90% are receiving or seeking for this health care. 90% of them receive the healthcare, and at the national level are based on the national scheme. In the case of Nayarit, is 39% for Veracruz. How many of these entities are included? That is to say, how many of these medical units within Nayarit we have the 285, and 30% are rurals, and Veracruz has 57% of them being rural. Nayarit doesn't have the third tier of the care, only the first and second tiers. For the number of workers providing services in the health area, Nayarit has an infrastructure. The infrastructure of the workers, 54% are health personnel, odontologists, nurses, specialists, and the administrative person, 23. For technical personnel 12, and in the case of Veracruz, they have less people devoted to these activities, 17 technical, 23 technical, and Veracruz has 26,000 workers in the health area. For now, the consultations and services in this particular case, on average, the consultations 1.3% of these consultations in the first tier for Nayarit and the rural area, and for urban 1.93 for Veracruz. We have a rural 1.18, and for the urban area 2.81. Now we'll move to the quantification and the results obtained by these gap calculations. In here we have the calculations for the resources available in dollars, in $1,000,000, and in this particular case, Nayarit, the green bars represent the calculation of the cost that we have conducted, and this is the ceiling cost. In gray color, we can see the resources provided by the states and the federal scheme that are located by the federation system, and they have this chart in health, and then we see the brown ones, and these are the method as a baseline, and this accounts for the fact we need some $17 million to provide all the overall services for the ordinary scheme in the case of the um, Social Security. And now, regarding the use of services from the federal scheme, we have a leeway of the $38 million. That is to say, we have a surplus. And in this particular case, Nayarit is spending more than they have for the service provision in order to determine the demand from the state. And for the case of Veracruz, we have exactly the same. The green bars are representing the calculation of the ceiling method with the ordinary method, and the brown bars are representing the ceiling methods, and they are insufficient for both cases. We do not have enough resources in the case of Veracruz to provide the minimum to determine the service, and we would need a further $135 million to provide the minimum service based on the use of services. And in order to provide the whole amount of services, we would require $148 million. And this methodology is applied for both populations without social security and under extreme poverty. In the two graphs, you can see that there is a similar behavior for methods. Thank you very much. Thank you, Raciel, for this interesting presentation about the process you conducted in Mexico. To continue, I will give the floor now to the Vice Minister of the Health Department and Social Protection, Jaime Orrego from Colombia, who is online. Good morning. Just a minute, please. I'm sharing my screen now. Well, I would like to greet on behalf of the Minister Jaramillo, Alfonso Jaramillo, and Doctora Maria Palma, ICLAC, for this meeting, and I would like to present my apologies for not being able to be there direct live. So we are presenting now this panel, and we would like to thank for this invitation to participate. In Colombia, we are going through a process of reform now. And I would like to highlight in the presentation, but sorry to interrupt you. Could you show the screen in presentation mode, please? Because we are seeing now the next slide. So up there, I think you have this setting there. If you can switch to this one.
I see.
Okay, now it's okay. Thank you very much. So I was saying before that Colombia is going through a process of reforms for the social security, not only in terms of healthcare, but only in the labor field and the professional fields. I was saying also that I agree with the proposals by Dr. Maria Luisa Merino in terms of the need to move towards systems of social security and healthcare that are based in the PHC and guaranteeing universality. And from that starting point, we'll develop the presentation. First of all, we should say that we have a law in force that is very close to the Constitution and develops the Constitution and also the fundamental rights and the fundamental core for the right to health as a human right. This dates back to 2015 and opens room for the public discussion, universities discussion, and to move in terms of these healthcare systems that are understood as a fundamental human right. This is autonomous, cannot be renounced, and for the collective and individual schemes. And this also includes the access to the health-related services with quality and to improve and to preserve the health. The government also ensures the quality of treatment and access to health care and also diagnosis, rehabilitation, and palliative treatment for everyone. And the benefit is understood as public and compulsory, and this is supervised and regulated and coordinated by the state based on the constitution. And additionally to this law, in Colombia, we have also a heritage of jurisprudence that is very important, and that is setting up this guarantee of public and universal rights, and is also a guarantee. From this point of view, I would like to tell you that before this law, we have since 1993 a health system that I will roughly present here in terms of categories, how it is organized. Our system is a system that is publicly financed by taxes and contributions and all other revenues that are contributing, and that is widely public in terms of funding. And the institutional design is a novelty at a point in time, and it responded to all the discussions that we had about the neoliberal model at the beginning of the 1980s and 90s, taking into account the fundamental principles of the consensus of Washington and taking into account also the experiences of other countries, and determined that the state at the state of the governmental tier, including these municipalities, has the control and the guiding, and we have these EPSs that are the agencies that are in between for the management and the service providers that are showed in the third circle, that are finally providing the services to the people, to the citizens, the users. In Colombia, for the people who are employed, that is to say, that can show a revenue, have a contribution, and the rest of the population is under a scheme that is subsidized. There is a solidarity pillar that is included in the general budget of the republic, and is also fed by other contributions by the citizens. This is very important in terms of coverage and the allocation of the support of financial protection that is virtually universal. However, we'll see that we have very difficult problems of access. Then we saw a new entity that is the administrator of the resources related to healthcare address that is remediating the economical flow between the state provided funds and the administrators that had or played the role of payers. This didn't disappear at all, but back in 2015, for 80 years, they start to transfer this paying function to a national organism to guarantee the payment to the hospital, the clinics, both public and private. And there is a very important instance of control and oversight that is a superintendency that is overseeing the government agencies, the providers of health services to guarantee the right functioning of this whole system and therefore guaranteeing the fundamental right to health. What have we seen in general terms? So first of all, through time, the health-related authority is weakening. Sorry for that interruption. Can you see now? Not now. Yes, now we can see the slides. Well, I was saying we saw through time, and this is a reason why we are in this process of reform now. The Colombian state, and according to the jurisprudence of the Constitution, provides to the state and the executive power this health-related authority, and this is getting weakened since these are under the control of the administrators that today are mainly private parties and are just a minority is public. Secondly, we established the segmentation, the organization of the health services as the integration, the vertical integration was included for these kind of players and the health care providers. And there is an integration, but in real terms, this spread to the rest of the country and it was deleterious for the rest of the rural areas. And there is this separation between the individual and the collective for the primary care, all the primary tier and the complementary tiers. We have the decentral that is based on a function. Financing that is structured based on the activities, technologies, and all the appliances calculated for the utilization in the healthcare.
Despite having a costing for preventive care, but in reality has not progressed in favor of everything implied by curative care. And in terms of resources, we have about 26 or 27 administrators in the country and thousands of providers, most public. And there was a method, a conception, ideology set up in terms of the provision of services so that the flow of resources is from medium to high in Latin America, in Colombia. But, however, the provision of services depends on the purchase and sale of services between the public and the final provider. A network means that we multiply the capacity of the public network. But this, in fact, ended up being dismantled and practically disappeared. And what is pending, depending on the private provision, which is not in itself a problem, but the logic is provided in cities where there is profitability, urban areas, not necessarily rural. And we also recorded a restriction of the professional services uh, and the pressure between financial profit and the quality of the services is a constant. And uh, precarious employment, 3,000 health workers, mostly women, that resort or work in the system via contracts. And as a trend, we see that the ensuring the access to health is restricted on account of the financial unsustainability of the system and the disappearance of the universal PHC based on territories and so on. So very quickly, what we began finding when we look at the behavior of the actors responsible of managing health risk is that, as you can see on the left in green, you can find the best behaviors, for example, for different surgical interventions, and these are the best providers. And clearly, we find that there is a gap in terms of lack of access to the best. And in the worst, on the right, we find access barriers that are very slow because the quality of the services is much lower. And so we require improvements in terms of quality and the coverage. And so here we see the disappearance of the republic and the presence of public and private providers in rural and urban areas. In the second map, the clearer areas have no rural premises. Close to 70% of the rural areas in the country have no providers, neither public nor private. And but yes, the services are concentrated in the major cities, which is you see on the right. The dense blue shows the concentration of services. This is a city of 8 million inhabitants. Here we find immense areas where there are more than 4 million people living totally unprotected and a total lack of health services. This business logic and profit, you find that the services that are not profitable for the people managing public resources leads to an inequality in the services, such as births, care for the elderly, and others. These services, considered non-profitable, do not appear only in rural areas, but in poorer urban areas as well. In certain areas of the larger intermediate-sized cities. So many areas have no delivery rooms and very reduced hospitalization services. Here you see that almost half of OECD countries appear here. Insufficient and inequitable distribution of human talent. Here we find that our averages in comparison to OECD and Latin America are low in all percentiles. And the relation of nurses per physicians is also very low. And so the problem is that we're not ensuring universal access, despite the existence of resources. Was we consider that the resources could always be more, but nevertheless, in general terms, those available are sufficient. And so we require a universal care, but the outcomes or the sustainability of the system would appear to be short. And so what does the reform entail? The state recovers the health authority, and it is a system financed with public resources coming from citizens. And so what is being discussed in the country, there is now a direct relation with an emphasis on PHC for people, families, and communities, and not clients individually. The administrators so far in a process of democratic discussion are asked to change their role, not to disappear, and that their role be a sort of collaboration, structural, and that does not imply neither resource management nor hiring providers because they are integrated and universally part of a national public system. And the entity formed to make payments would be at the base of the arrangement with greater demands in terms of what is paid in order to ensure the direct transfer to public as well as private providers in the country, strengthening the surveillance and control by the national health superintendents. Here we see the reform model. As you can see at its heart, we have recovery of the public infrastructure, although they can also be private or hybrid throughout the territory, and units of up to 20,000 inhabitants in urban or rural areas, depending on the geographical location. This connects the community, family, and people through territorial teams that are sent and see the home, the school, the community, the workplace. With an intersectoral approach, and here on the right we see the number of hospitals that became companies, and they would once again become public, that do not compete for the resources, but that work in a cooperative manner and are financed directly in this new model and the reform being discussed in Congress. Of course, maintaining the supplementary low, medium, and high complexity, non-discrimination, dignity, and at the bottom you see the manager, which is an interesting figure in terms of the democratic discussion of progressively transforming, respecting the historical dynamics, but that would move on to support the management of the overall system and supplementing the PHC strategies. And so, what lessons were learned with the crisis? As Maria Luisa said, universality is imperative, understood not so much as the coverage or individual financial protection. Of course, that per capita component is there, but in terms of access and the right to health, in no case should depend on their ability to pay. And two, the heart of the reform is focused on recovering, expanding a primary health care system and that is provided universally for everyone, regardless of their regime of contribution or non-contribution to the system, because under the current systems, care disappeared uh, in areas where people live. And a third thing that has not been much mentioned has to do with health sovereignty. The COVID emergency left us with this lesson learned in that nationwide and also regionally, and we are working on this. The President mentioned it in Argentina and also now in the EU. We need health sovereignty, scientific and technological development, and the regulation of all medications, inputs, and technology, because these are elements that are putting pressure on health expenditure. And also, when we're asked about the obstacles, what we find in the reform process is that we have seen an ideology that is ingrained in society today, that it is an area that is based on competition, so that health is a business. The Colombian regimes, the constitution says that this is a right, and the fact that people can live within the system, providing the health, nevertheless, this is sacred and must guarantee essentially the right to access health services and not in order to capture public resources. And so other models based on disorders are unsustainable and reproduce inequality. Health is a right, not a business. Health should be considered as a public good, a common good versus a good that is bought and sold on the market and that depends on the individual ability to pay. We're moving towards a very interesting process, and the issue of health was on the table as the central issue in Colombia. This exercise has been very interesting in terms of incorporating all current discussions around the world with regard to universal health coverage, understood not only as protection and financing, but health services, interculturally, participatory, and sustainable. Well, that is it, and we're open to questions. Thank you. Thank you very much, Vice Minister, for that very interesting presentation on the process in Colombia. And now, our last panelist, Agnes Sucat, Director of Health and Social Protection at the Agence Française de Développement, who will be with us online. On account of time, I will ask you to please keep your presentation to no more than 15 minutes because we're running a bit late, but we do hope that you can connect.
Thank you very much.
I remind you that Agnes will speak in English, and so therefore you may use your headsets to hear the interpretation. And in the Zoom, select Spanish if you prefer. Thank you.
Thank you very much and good morning.
Muchas gracias y buenos días
Good morning to all.
a todos y todas.
My presentation will be
Mi presentación
different from what
va a
has
ser un
been
poco diferente
presented
respecto de
so
lo
far,
que se ha presentado hasta acá.
in the sense that I am going to share with you some broader perspectives from different parts of the world and try to share with you a bit what we have learned by analyzing health spending in the world over the past 2 decades and relating it to progress in universal health coverage and measuring universal health coverage using 2 main indicators: the indicator of service coverage with an index putting together 16 indicators, mostly primary healthcare indicators, and the indicator of financial protection. I hope you are able to see the slides, so I'm moving to the next one.
Yes,
So
I'm sorry, we're not seeing as a presentation.
You're not seeing the presentation. What about now?
But we can see. It's okay. Okay, you can continue.
You can?
Yes, we can see. Please continue.
Okay, very nice. When we look at what the global spending on health is today in the world, the first thing that I want to emphasize is that spending on health and the health industry, in a way, is a very important part of the economy, and that's been mentioned by previous speakers. It's a source of economic output, of economic growth. It's also a source of jobs. And it's been said a lot that health spending should not be seen as an expenditure, but as an investment. But it is very much so. And in fact, modern economies in the 21st century give much more space to the health industry than economies of the 20th century. And what we see is an increase in global spending on health that is much faster than the increase overall of the global economy. Latest data that we have that we are confident they reflect the experience of countries are from 2020. So during the global pandemic of COVID-19. And what we know is that global spending on health is about 9 trillion, which represents about a little bit less than 11% of global GDP. So it's quite a sizable amount if we say that a tenth of our common wealth is actually produced by health services and is also consumed in terms of resources to deliver health services to people. We think that this health spending is actually was up in 2020 from 2019 by 5.8%, which is of course related to the pandemic. The pandemic led generally to increase in health spending, not universally. Some countries actually did not see an increase in health spending and some actually saw a decrease in health spending. But overall, on average, during the pandemic, health spending has increased by a little bit less than 6%. What we know also is that most of health spending in the world today is public. 63% come from government resources and 36% from private resources. And that what is called overseas development aid or development assistance is actually very little as compared to what is spent today in the world. It's about 17 billion, and that's 0.2% of global spending. The share of public spending has been steadily increasing over the past decade. So when we see is when countries become richer, they tend to tax more. And when they tax more, they tend also to spend more public money on health, and they tend to fund health through a collective mechanism. And that's what we see in societies that get richer. You see citizens asking for more collective spending of health. Let me see. Yes. So that 2020 experience has been quite interesting to see how the world has reacted to a global health crisis that was universal. Every single country has been affected. It's been a unique feature in history. All countries had to respond to a health crisis. What we know very well now, we knew it from before, but now it's the evidence is overwhelming, is that a health crisis can provoke very significant economic consequences. As the global GDP fell 3.4% from 2019 to 2020, and the total global spending on health yet increased while this GDP was decreasing, which means that countries run into debt. They got indebted to respond to the crisis. They also shifted expenditures from other sectors. And in general, the priority given to health increased from 2019 to 2020 in all income groups. What is different in high-income countries, in OECD countries from other countries, is that in OECD countries, it's total spending that increased, total government spending, including social protection spending and cash transfers, safety nets, in response to the shock. While in poor countries, government spending did not increase. It's only health spending that increased, and that basically created a substitution for spending in other sectors. And we know that spending on education and infrastructure in many countries has decreased when countries had to increase financing for health. So what we see, here's the latest data, so between 2019 to 20, you see in high-income countries on the right, you see that government spending on health has increased from 2018 to 2019 to 2020. We see a similar pattern in upper middle income countries. And we see something slightly different in low and lower middle income countries, in which we had actually seen some expenditures that were going down over the decades before 2020, and they surged during the crisis of COVID-19. So across countries, average per capita government spending on health increased in all income groups, and it rose faster than in previous years. When you look at international solidarity, it's somewhat a surprising picture, because you would think that when a global health crisis hit the world, you would see a surge in global solidarity, and certainly there has been a mobilization of countries providing development aid, and there's been a mobilization to fund some aspects of research, certainly BARDA in the US, and some European Union funding went to the research for COVID-19 response, particularly vaccines. But generally, what we found surprising is that in 2020, spending from external aid, external development aid, remained close to the 2019 level. So has not been a major increase in financing, international financing for health in 2020. What has happened is mostly a reallocation of both domestic financing and international financing, basically using the funds that were allocated to general health services to respond to the COVID-19 crisis, but not necessarily increasing funds and providing new sources of financing to health. Just so aid has remained stable. It was 20 in poor countries. So here you say that this is a list, this is a picture of 20 of the poorest countries in the world, the low-income countries in 2020. And you see in green is external aid, in blue it's government, and in red it's private. And here what you see is something that we've been observing over the past 20 years, is that in poor countries, most of the funding for health comes from out-of-pocket spending, from private spending. And for some countries, there is a significant amount of development aid spending that is on average about $10 per capita in 2020, just a marginal increase from 2019. And that generally private spending remains the largest sources of health spending in low-income countries. What you see, which is really striking, is how small the blue part of the graph is, which means the public spending, public domestic spending in poor countries is extremely low. And in fact, has been decreasing over the past 20 years. So this idea that you would have a natural evolution of health systems over time where public spending takes the largest bulk of financing is not happening in poor countries. There has not been a formation of institutions that collectively finance health. And one of the explanations for that is that development aid may have a substitution effect. So in fact, in 2019, external aid remained higher than government spending on health in most of these countries. And what could be a very worrying explanation is the fact that external financing is replacing domestic financing, and that countries receiving a lot of external financing actually choose to reduce their spending on health and move public spending to other sectors. So a trend of concern globally today is, despite the fact that globally we see health spending increasing, we see public spending on health increasing, this is happening mostly because high-income countries and upper middle-income countries increase their spending on health and increase their public collective spending on health. But low-income countries and lower middle-income countries are actually not increasing their public spending on health. And this is very much a concern when we see that most of the spending on primary healthcare in those countries is out-of-pocket spending, and we don't find a clear relationship between the level of public spending and the coverage with primary health care, which means that most of public spending in these poor or these low income or low middle income countries is actually going more to hospital care and providing some level of financial protection, but find it difficult to reach the poorest populations and find it difficult to reach frontline services, particularly primary healthcare services. So this aspect of crowding out of aid is quite substantial. You see in low-income countries between 2000 and 2019, so it's a 2 decades. It is a very large number of countries. It's more than 30 countries. You see in blue the public spending tending to decrease, while in green aid spending is increasing, and you see very little change in private spending, which remains at close to half of the spending on health, 44%. And this private spending is largely funding primary health care. So when external aid increases, that you see here in green and yellow, it's both external aid for health that is delivered through government, when governments receive funding to support their budget and their expenditure program, but also external aid for health through other channels in yellow. So you see between 2000 and 2019, this has been increasing, but in the black line shows the decrease in public spending. So we really have a major question there about changing the way we look at international solidarity and the way we look at the construction of institutions at country level to deliver on universal health coverage and deliver coverage on primary health care. Because over the past 2 decades, whatever we've been doing collectively in terms of supporting policies and investments in low and low middle income countries has not led to major improvements in the formation of institutions that deliver collective financing of health, and particularly financing of primary health care. If I look at the results,
Agnes,
and here these are...
I'm really sorry, but we are out of time. So
Okay.
please, I'm really sorry, but I have to ask you to finish in no more than 5 minutes, please.
Okay, I will do that.
Thank you.
If you look at the results of this financing of health globally, and you see the progress in service coverage, these are the indicators that are measured in every single country in the world. So you have the UHC index with 16 indicators, and these 16 indicators can be divided in 4 sub-index. One for reproductive, maternal, and neonatal and child health, one for non-communicable disease, one for infectious disease, and one for service capacity and access. So you see this index over time has improved. And in fact, calculations of experts from the World Bank and WHO conclude that about half of the world has access to health services, to primary care services. But when you look specifically at which indicator improve, you see it's the green one. It's the green curve, which is infectious disease. And in fact, this curve is largely driven by one indicator. The progress is driven by one indicator, which is the indicator of coverage with antiretroviral therapy for HIV. And that coverage was low in every country in the world at the beginning of the 21st century because it was a new intervention. So in fact, we have a kind of statistical issue of regression to the mean, in which we have, in fact, this measurement of universal health coverage, which is very affected by the infectious disease indicators. And the improvement in the other areas is actually quite limited. There is a bit of improvement on the orange one, which is reproductive, maternal, and child health, but there is very little improvement for non-communicable disease. And more worryingly, and that's been one of the lessons learned for COVID-19, there has been almost no progress in health system capacity, and very little has been invested in building the health workforce of the 21st century. And as many of you know, we now face a global shortage of human resources, which really became really very evident during the COVID-19 crisis. So let me just finalize to finish this and shorten my presentation by just showing this this graph, which as a summary. First, saying that when we look at coverage with primary healthcare, income is the main driver. And that is not what we like, right? We all like the fact that governments are important and investment is important, and they are. But the fact is that income around the world is still driving coverage, and it's still mostly out of pocket spending by poor people who is driving the coverage with primary health care. We know that that people with more money spend more, and that nonetheless public finance and public policy matters. What is very clear from the data is that public financing of health, collective financing of health, into providing social protection on health, is extremely important in reducing catastrophic health spending and reducing poverty. And there we have a very clear effect of public spending as a social protection mechanism. And that was very much the case during COVID. So where we are today is this graph here, in which you see that this is the evolution of the two indicators of universal health coverage. You have as an x-axis UHC service coverage index that is improving, but is not improving completely. It's improving mostly because of the infectious disease indicators. And you have the financial protection indicator, which is actually getting worse. So in fact, there are more and more people who fall into poverty or spend more than what they can afford because of health. And one of the reasons is the fact that the public spending on health in low income and low middle income countries has been decreasing. So 7 years away from the SDGs, we need different strategies if we are to reach UHC. Only half of the world has access to primary healthcare services. And we all know that this half is the easiest. The other half that doesn't have access will be much more difficult to reach, and we will need new approaches that will include social protection, cash transfers, special programs to reach out vulnerable populations. And this will need renewed public investments in health services, including massive investments in creating a workforce that will be fit for purpose for our objectives, our global objectives. Thank you very much.
Thank you very much to you, Agnes, and for your comprension. Bueno, por temas de tiempo, lamentablemente.
On account of the time, we will not be able to have a time at the end for Q&A, but I would like to remind those of you who are connected online, please answer the survey, which is in the chat, and in those in person, the QR code that you have in your place. And lastly, I'd like to thank our official speaker, Maria Luisa, for her very interesting presentation, and the three panelists for the three different views that they shared, the two cases of Mexico and Colombia. Now, with the international approach by Agnes, thank you very much. And I believe that we're all in need of a bit of coffee, so I now invite you to share coffee outside, and we see you back here in 15 minutes. Thank you.
Buenas tardes.
So, good afternoon, everyone. On this international seminar on inequalities in access to health, the centrality of primary health care to advance towards the universal health. We thank everyone who's here in person as well as though online, close to 400 attendants. We are now moving on to the panel 2 on PHC as a tool to advance access and universal health coverage. And we are going to review various experiences to overcome inequality. For this, we have one keynote presentation and comments by experts. And so we welcome everyone. And the PAHO strategy ensures the highest possible level of health and well-being, and it's an equitable distribution, focusing on individuals and communities throughout the life cycle. This includes interventions ranging from promotion and prevention to treatment, palliative care, and rehabilitation, and the first level of care with high resolution capacity. The central role of individuals, families, and communities will be addressed, as well as the participation in meeting their needs, expectations, and rights. I would now like to recognize James Fitzgerald, who's with us online, Director of Health Systems and Services at PAHO WHO, and he was speaking to us about the centrality of PHC. James has around 20 minutes. Thank you. Well, thank you very much, Antonia. I'd like to check if you are hearing me all right. Yes? So, merely, I'd like to thank you and, above all, recognize the countries who are present at this very important event. And above all, the panel recognizing, in particular, Dr. Bernardo Martorell, coordinator of the Health Reform Ministry of Health of Chile, Dr. Edwin Montúfar, who's Vice Minister of Primary Health Care, Ministry of Public Health and Social Welfare, Guatemala, and our colleague, Jennifer Nelson, who's the expert on digital solutions for health and social protection division at the Inter-American Development Bank. So I thanks to everyone, and especially ECLAC for having organized this very relevant discussion at this particular time. I believe the discussion is relevant because, as we are all aware, coming out of an event which has been the greatest in terms of public health impact worldwide of the last 100 years. Obviously, the pandemic has had a tremendous impact, not only in terms of mortality, but also the morbidity and excessive mortality, in addition to socioeconomic aspects worldwide. And what does concern us as the PAHO and WHO is how it has also had an impact on the indicators on universal health coverage and access to universal health, and in general, in terms of the goals agreed on for 2030. We have seen an expansion of inequity in health in the region, with relevant trends in terms of maternal death and lack of proper access in the last 3 years. And so it is absolutely urgent to support countries in improving access to health care with the concept of resilience of the health systems, inclusiveness, and preparation for any health emergency that may affect the region in future. As you well know, primary health care is a strategic approach in order to address the needs of people and communities where they live. It is very much focused on people, the community, as a model of care that should respond to the differentiated needs of the population, regardless of whether they live in cities or peripheral areas or rural areas. In order to understand the context of Bajo in the 21st century, it is also important to understand the history of primary healthcare in the region. The alma mater, adopted in 1978, was a very important milestone, and right now represents the main strategy with which to address health needs throughout this period. Unfortunately, as we all know, we had a fiscal crisis in the 80s, and this, together with the processes based on reforms and functions, all of this has had a tremendous impact on the ability of health systems in the region to address primary health care with an integrated approach, responding to people's needs. And so this has resulted in health systems that are highly fragmented and populations that were unable to get out of these segments and in order to respond to their needs. And so Pajo has had to face poor services. Then we moved on to the 80s when we suffered the HIV pandemic with great investments made in order to address this challenge. One linked to this, in 2004, there was a call or a movement to address the verticality of changes that were needed, with at the same time renewing the PhD. This was a call on all countries of the region to address reform, and this that had produced so many segmentation and fragmentation in the health system in order to address health needs far more holistically, focusing on families and the community, and designing health systems based on the needs of the population. And then in 2010, we had a global movement towards universal health coverage, and this movement led to a lot of discussion in the region of the Americas, because what the member states were saying to Bajo, that the culture, the concept was important, but insufficient. And so what was really important was a need to address access barriers, which are geographical in cultural and financial terms, if we are really going to face the needs of the population where they live. And so the concept of universal health as a concept did guide the reform process that we've seen since 2014 in the region of the Americas, based on extending access to comprehensive services based on PHC, improving public financing and reducing out-of-pocket spending, and improving the governance and the leadership of these health officers, and addressing the social determinants of health. And so we reached 2018 and 2019, celebrating the 40 years of the alma mater in the region, and together with the WHO, we called attention to the progress achieved, but also a lot of attention to the inequalities that were clear, lack of financing, and the efficacy of what was being done. And so the social challenges in terms of human resources, the concentration of hospital services in the health services, the high cost associated to the provision of these services, and lastly, something that we were not actually reaching the population that still needed integral health care. And I think it is important to recognize this history, because One way or another, it also explains how COVID-19 had such an impact on the region of the Americas. The lack of comprehensive and effective health policy for decades, lack of resources, and hospital-centered services were all perverse incentives linked to new technology and the issue of the workforce. All of this led to a very highly inequitable system, inefficient, and with lack of resolution to the, especially in the face of the pandemic that we had to face. Recognizing this, Mr. Barbosa, who is the director of the PAHO, has determined several priorities for these countries, and two of these are to learn from the lessons learned during the pandemic in terms of the performance of the health systems, and then to transform the health system based on PHC. In the post-pandemic period has implied tremendous effort by countries in order to address waiting lists and recover the public health achievements that were lost in the last 4 years, to address inequalities even greater today in the region in order to ensure universal access to health and the sustainability of the health systems. And so the need to address the trends in terms of mother and child mortality, and given the coverage of the immunization campaigns, the idea is to deconcentrate and the health services in order to address communicable diseases and extend access to services that should be far more comprehensive in order for the control and prevention of chronic disease and also mental health. And all of this under the lens of equity as the key to action. And so the strategy that PAHO right now is using in order to develop capacities at country level is based on three main axes. First of all, access, second, coverage, and third, quality. In terms of access, universal access is the main goal of PHC, and one of the main challenges, not always addressed in Latin America and the Caribbean. We are informed that there are tremendous demands, unmet demands in health systems after the pandemic that have an impact on more vulnerable populations, low-income rural populations, or population with low levels of schooling. These groups are greatly affected, and they need a differentiated strategy with the focused on equity. This is very important when we design health services. We should achieve a certain level of services, but also taking into account the access barriers that I've already mentioned. One thing that is of concern to us and that we are addressing is human resources. We cannot ensure integral health services without paying attention to human resources. We have a lack of human resources. We believe that almost 600,000 health workers are needed if we're going to resume our pathway towards the SDGs in the region, and also the challenge linked to the distribution and the quality of those human resources. But unfortunately, most continue to work in urban areas and seeking to specialize in what they do at hospital level. So there's a tremendous effort by the organization right now to address human resources for PAHO, the collaborative side, you having professional teams and working based on the needs of the population. This brings us to another priority linked to access. That is the territorial approach. The organization is very much aware that a lot of work has been done in terms of health policies based on universal health, on PHC, but this is not translated into plans, territorial plans at the national level and local level, and developing the care models that should be adapted to local conditions. And this is something that we need to strengthen here on. And then coverage. Effective coverage means the availability of health services throughout the life cycle, and that should be integrated at all levels of care. And this involves several integrated networks. And so this implies that what we need is to substantively review the coverage needs, ensuring the services that are being provided respond to the needs of the population that they're addressing, especially considering communicable diseases in order to resume coverage levels in terms of immunization and mental health, and of course, control of and prevention of communicable diseases. We need to promote health, preventing illnesses throughout the life cycle, seeing people and the context, communities, and the needs of each population group during each stage of life, and optimizing and building the services that are needed based on this.
This also implies that we need to consider the social elements for public services, for everything that is related to sanitary issues, the services of health, the schools, pharmaceutical area, labs, and to strengthen the link between the individual services and the public health services, considering the needs of the community. And this is really the integration, articulation of the PHC. Now, in terms of quality, quality is an intrinsic concept that is related to all these areas and that require a specific approach right now. We have seen that according to what we have presented to the executive director in June this year, there's much to be done in the region of the Americas in improving quality. We know that there have been certain improvements in terms of balance and leadership and in promoting the culture of quality and health. But finally, there is a need for more attention in the different health services in terms of improving quality, to improve processes, to ensure the safety of the patient, but above all, to ensure monitoring and assessing the health results at this level. This is something that really stands out from the countries of the region, and it needs an approach that is related to the PHC strategies. And of course, this access approach needs a sectorial, intersectorial approach with a cross-section between academia, technology, health, and of course the representation of the different sectors. Here, we need to support and strengthen the capacity of the health sector and the interactions between other sectors, so that the interests of health can be seen reflected in the different policies of the sectors. But for all this, the organization is focusing in actions for three specific areas. First, investment. The second one, innovation. And the third one, implementation of primary care. And we can see these three actions that we are promoting. First, We know, we have all said that public expenditure in health is still very low for the region of the Americas, around 3.9% in terms of the GDP. And this is very far from the 6% that was agreed upon by the countries in 2014. It is just now reaching 6%, but far less than the 20% of the out-of-pocket expenditure. So this fact, all related to funding, has to be taken into consideration with more resources, knowing that the main expenditure of the region needs more investment and thus expand the system to establish a smaller gap between these areas. And there's a need for training of all the professional teams and their own integration in their areas of work. Related to this, and calling the different countries for more investment in public health systems and the capacity of public health, all related to the possibility of responding to the sanitary aspects, to surveillance, to regulations, some basic actions that are needed to strengthen the capacity of the health systems based on PHC implies more investment in the essential functions of public health, all related and integrated to PHC. The second axis then is innovation. Innovation in primary care can be recognized as a key element in a world that is very different to the world that we had 5 years ago. We have different contexts, different populations, we have different needs. And what we need is to find a way to ensure innovation, not only at technological level, but also political and social, to ensure health rights to all. We have seen a tremendous acceleration of innovation in digital health and technologies that probably Jennifer will be mentioning. But what we would like to rethink is the model of care, all concentrated and based on differentiated aspects, considering their context, their epidemiological context, the sociological context, and the new demographic reality that exists in the sub-territories, as well as all of the levels of the different countries in the region. In governance, the organization of services, priority programs, the processes of all of the care, technology, innovation, and the continuity of the care and the intersectorial cooperation, everything is necessary to work together. And we again need to have interventions there to consider the challenges presented in communicable diseases and long-term care within these contexts. We have seen experiences that are quite innovative in terms of funding and that we have to carry out and see whether we can implement in the systems. There are tremendous opportunities and a focus of action for us in the future. And the last element is that for PAHO, the idea is to support countries in its implementation. Implementation is a key element where we go from the political relationship to the policies themselves and from theory to practice. We are fully convinced that we need to act and act now. Therefore, what PAHO is doing is establishing a priority in the territorial area by calling all local stakeholders, local governments, communities, and others to be able to create pathways or roadmaps, local plans, considering the specific needs, and of course, all properly integrated with the different actions at subnational level and national level to be able to approach all of the local needs impacting the results themselves. We are then pushing forth a very important activity of exchanges in primary care throughout the region and analyze as deeply as possible all the different experiences and thus be able to promote exchanges between the countries. Strengthening the leadership and governance and all the capacity associated at the different levels is a critical element. This is how we will ensure and support the different countries in validation mechanisms of performance at local level and national level in the effective implementation of this strategy. Colleagues, this of course cannot be done by ourselves. We are very thankful to this initiative of ECLAC in acknowledging the tremendous capacity they have in linking the different sectors related to this initiative. It is really working very strongly with the multilateral banks and other partners and stakeholders from academia and professional sectors. This is a strategic alliance that are crucial if we want to take all capacities and knowledge that exist in the region to be able to create this agenda and be able to build upon the systems that should be more inclusive, more resilient, and based on primary care for the 21st century. Leadership of the national entities is a key element. We have seen many countries such as Chile, Guatemala, Colombia, and Brazil, but in many other countries as well, in the Caribbean as well. Everybody is making tremendous efforts in this very small window that we have right after the pandemic and probably going into a different emergency in the future. This window of opportunity of this action period is very short. We need to build and create more investments, innovation, ensure the implementation of PHCs that will ensure, promote, and guarantee health for all. So thank you very much. And I will be here with you an additional half hour because unfortunately I have to go to another panel of discussion. So thank you very much. Thank you, James, for your wonderful presentation. The emphasis of the historical role is very interesting, and the relevance that exists today in a comprehensive approach and the structural weaknesses of the countries in the region. As you mentioned, PHC allows to consider the challenges of the region and to look in a solid, resilient way, and to be able to consider the barriers for universal access to health, responding with multi-sectorial policies, to be able to move forward in universal access. And thank you for considering all these relevant elements in innovation and others, and to be able to use this window of opportunity. So thank you very much for your presentation. We will now like to offer the floor to Edwin Muntofer, Vice Minister of Primary Healthcare, Ministry of Public Health and Social Welfare, Guatemala. You have around 15 minutes, Doctor. Thank you very much. We do agree in the different perspectives of the presenters in primary care, in the area of primary care. What is so specific about this strategy is how it is possible to adapt to different contexts, to resources that each of the countries have. These meetings, these conversations, this fora allow to identify strategies that are being implemented in the region and can help in improving universal access. As we mentioned it at the beginning, the changes in the social determination of our systems, the health systems that are so weak, the new emerging diseases, means that the health systems have to transform and adapt to these new contexts and guarantee universal access to health service or health care. we can see here a special situation. We hear that there are goals to fulfill. Nonetheless, the COVID pandemic is just a specific element. Many of our countries suffered economic impacts out of which they are still not recovered. And to be able to implement interventions in health, we need financial resources. The challenge, the 30-30-30 challenge, sounds very far for many countries. And it means that we need to turn to our services of our organizations in terms of optimization of resources. The need to transform our health systems has changed the epidemiological profiles. The life expectancy of population has increased. Populations are starting to migrate from the rural area to the urban areas, meaning that there are new lifestyles. Our health systems were designed to care for population that was basically rural populations and transmissible diseases. When widening the profile or life expectancy, when changing from a rural context to an urban context, means that there are changes in lifestyles requiring new education and health to promote healthy lifestyles, meaning that there's a need to adapt our services, the profiles of our professionals, and thus be able to respond to this epidemiological reality, to these new ways of living that are being installed in urban areas, to that new demographic group that we have in different countries and that have made differences in the responses of survival to pandemic.
Guatemala has a population bond and until 2059. And with that, its mortality rate due to COVID wasn't that big. But likewise, our health systems should be able to respond to these emerging situations like climate change that is striking us very hard in the beach in such a way that these learned lessons show us the importance of transformation of fragmented services towards comprehensive integral services according to life cycle stage, where leveraging from lessons learned, we can address the population with ambulatory services, agree on service by stage of life cycle, differentiated, allowing for access and coverage of our services. That has been one of the lessons learned in our country. The importance of continuity of interventions. The planning in our country is short term, they last the time of public administration. But if they are ongoing, continuous, we can see medium term results. And that is one of the characteristics that primary care, healthcare should have. Technology is key for that. We see it in education processes, updating our human resources, but additionally improving access to health services. When services are not accessible, then technology allows tools, uh, permits saving life. It's a new paradigm and at the same time facilitating and reducing administrative processes when technology is involved. It calls for major investment. Indeed, you need to overcome change resistance and economic investment in automating systems. Those processes cannot be delayed. And at the same time, it's important to have controls. There are so many actions in primary care, but they are invisible. They are only evident when there is a health crisis. That calls for technology control boards. Population is ever more informed with access to the media and calls for attention and care. The pandemic taught us that we needed to have information boards, and primary health care also needs communication. Population demands being interconnected, communicated. I cannot add any more to that said by my predecessor. He was very explicit, but I want to thank you for your attention. Any questions? Here I am. Thank you, Dr. Montúver, for mentioning key elements for APS or PHC. It's so important with the complex needs. The changes you explain not only involve challenges, but also opportunities to be leveraged. These meetings of collaboration are designed to generate common strategies, common lessons, and in each territory to move forward in a universal health, considering the heterogeneity of persons and communities. Thank you again. Now we give the floor to Dr. Bernardo Martorell, coordinator of the reform of the Ministry of Health of Chile. You have 15 minutes, Bernardo. Thank you. My PowerPoint presentation? Yes. Thank you. Good morning, everyone. Thanks for the invitation to ECLAC for this organization that allows us to have a dialogue in terms of the challenges of our countries, and also thanks to the speakers for their very interesting comments. Regarding the subject we are addressing, especially in the roundtable with James, Edwin, and Antonia, who is doing an excellent moderator's job. Thanks. I was asked to refer to primary health care. The Undersecretary made a presentation on the axis of the reform and did it in a very robust way. And also, his presentation was based on primary health care. I will take a few of his ideas and go deeper into them. It is a big challenge, the one we have on this matter, with many nuances and aspects difficult to achieve. I want my PPT. Well, I will start. Yes, I will start. I have the slides in my notebook. The first statement I want to make is that health is the main wealth of a country. And that wealth, in some way, is the matrix in which all the other activities of a society, of a country takes place: economic, social activities, all other objectives we have as persons in life are in a matrix that is based on the health of persons. Thus, the subject we are discussing about the future of our civilization, of our countries, as the Undersecretary said, of how do we establish a care system allowing for that fertile land that will move towards the blooming of all plants, to say it in other words. And there, the economic case for primary health care, Maria Luisa Marino referred to that. And here we have a table about the concern of an economic case for primary health care, how primary health care contributes to the economy of a country. It's important that in a forum on primary care, we underscore that point. Maria Luisa did it from a different perspective, but taken from all these authors from WHO, or how primary health care improves health equity, efficiency, less hospitalizations, less costs, improves the health of the population and generates economic benefits, allowing persons to work. It is a source of work. As Agnes said in her presentation, it is an important source of employment. It's the main, public health is the main employer in the country. And primary health care is 40% of the labor force of public health system. So primary health care generates benefits in health and economic benefits as a whole. And what we are raising is not something out of a hat or out of a box, but it's the result of a long-standing health tradition and one of development as a country. 99 years back, next year will be 100 years from the enactment of the workers' insurance in the country. It was in 1924 under Arturo Alessandri Palma, as a package of social measures with the elimination of child work, the strengthening of trade unions, and many other reforms in that package. That is a signal of how in the last 100 years we've had a certain challenge of moving forward in health and social issues in our country. And this is consolidated in 1952 with the creation of the National Health Service, that in the subsequent decades of 60s, 70s, and 80s, maternal child or mother and child health improved, and also reducing infant mortality. And our countries, we have infant mortality or maternal mortality at rates that are equivalent to the most developed countries. And also, our declaration, the Declaration of Alma-Ata, it has been a landmark, a foundational landmark in the health history and primary care from the 80s, since the 80s, with reforms separating functions, activities, decentralization, primary care placed as something completely focused, poor for poor in 2005, there is a reform where saying primary care is the center of the care model. There is an integral model for primary care. However, those reforms did not go along with relevant structural changes, allowing for primary care really to give a major leap forward. And now the World Health Report referred to this primary health care reform, recognize the epidemiological transition, new health challenges, and how primary care is an even more relevant response for those new challenges. In 2018, a preparation for the 40 years of Alma-Ata with the Primary Care Congress and the Astana Declaration of WHO, following the Alma-Ata Declaration 40 years anniversary. And we have, in some way, we have built on that story, on that history. And that is why I've told you about this trajectory we've treaded so far. Our primary health system is made up by a national network with an exhaustive distribution throughout the territory with a diversity of facilities. The largest ones are the CESFAM family care centers and community hospitals, 600 facilities, and other countries have 100 to 150 workers each one of those facilities, and covering a population between 20 to 40 to 70,000 persons in some cases. Population registered in those CESFAM primary care centers. Those mother facilities in the territory have also smaller ones, which are the community family health centers, 286 of them, and also an emergency network and rural emergency centers, quite exhaustive with important coverage throughout the whole territory. The administrative organization of primary care in Chile is the country is subdivided in 29 health services covering all the districts, 346 districts, or 236, sorry. And it is the municipality, the town hall, that administers primary care financed by the Ministry of Health with a per capita investment. And then there is also a smaller percentage depending on the health services of the territory that are financed not through a per capita system, but through one of historical budget. That is our network of primary care in Chile, covering all the population. Until last year, it covered all the FONASA population.
Additionally, with 100%, that is to say 15 million people who are registered in the public fund of healthcare, that is a very high percentage of the population in Chile. And out of that number, 80% at the same time is registered in the PHC centers, and 50% of this population, more or less, is using the services on an annual basis. That is to say, they get in touch with these centers for PHC, and this is a network that is very robust and covers the most vulnerable population, as well as the populations from these different social media. And we are now facing this situation that leads to these reform processes. As it was said before, we had this epidemiological situation that is characterized by the multi-morbidity, and this is one of the main features of our population, that is to say, people who have 5 or more chronic diseases, inequalities in health that are very important to underscore, that translate into out-of-pocket expenditure. The Undersecretary also shows some data, the dignity in terms of sanitation, how people expect to have a certain benefit from the health system, that they do not find this response in the right timely manner. And there is here a main shortcoming in our system, and the citizens are living this on a daily basis as a concern, as a malaise. And last week there was a new survey that is positioning this reform of health over the retirement ones as one of the main priorities in terms of social reforms that are required. And finally, the concern for the sanitation or health security. I was reading here at the wrong place. And finally, the health security that is very important for the population. As we mentioned, the pandemic, we are living on a constant basis with disasters, floods, fires, and volcanic eruptions. And the healthcare system is the first one responding to those catastrophes, and therefore we should have a certain level of care and benefit in any event. And during the pandemic, unfortunately, the continuity of those services was interrupted, and today we're paying in a certain way the consequences of those displacements in the healthcare provisions. And this system is fragmented today, and a comprehensive diagnosis has been conducted. Edwin already mentioned this during his presentation, that the services are fragmented. We also saw that in the presentation by Mexico, and this is the result of the worldwide situation with the segmentation, the commercialization of the medical services, and also the hospital-centric approach. And people are kind of cut up in pieces according to their diseases, and we know that the people have multiple diseases at the same time, and they do not receive a comprehensive treatment. We care or treat them according to their social economic situation. In Chile, we do also a distinction in this case, and this defragmentation has a different difficulties or shortcomings that should transit towards the territorial approach, as it was said by Pajo. And this is a system that should be built jointly with the citizens, the people, and that is also empathetic with the needs of the people in the territories based on their needs and their cultural outlooks and social perspectives. Obviously, this should be linked together with the multi-sectoral and territorial network. The Undersecretary showed also how we had these guidelines for work, and I will delve into some of the items of this theory for change and the effective access with quality. We are understanding maybe the concept differently from the understanding of the World Health Organization, and we are just starting as a pioneer project. So the first step is that we have some difficulties for infrastructure. It's difficult for people to have access to the healthcare they need, and we are frequently living some discriminations. The discrimination, social discriminations, are duplicated towards the elderly people, people who are mentally disabled, people from different the diversity sectors and cultural backgrounds. And all of this is duplicated in the healthcare system, and we have the third ranking with more mistreatment according to different surveys of that is to say, compared to the street situation and the workplace situation. And we are having this situation also in the healthcare system. And the lines or avenues for progress. So we have, for example, the program for telemedicine. The people can um, ask for these services through their cell phones or in digital platforms. And this request is not just for the appointment, as it happens in the private scheme, but also in order to describe um, briefly the situation, the pathology, in order to manage this. This is a very important first step because it allows to optimize the use of resources. We have a history of use of resources where it is very difficult to improve. And part of the work that we're doing based on this strategy of telemedicine is in order to improve the points of contact and the resources that are available. Another point I would like to highlight is the infrastructure. And I will move immediately to the next slide, which is here. The point related to infrastructure. For the primary care and the universalization of this is one of the major challenges. When we go to a district and we say that this is being made universal, they say that there is no more space to do it. But for this new population, we will need 3,628 new boxes. On the other hand, the present infrastructure is composed of big buildings, and when we receive visitors from other countries, they say that the family health centers are like hospitals because they have many square meters in area. And this is not favorable for a kind of service that is personalized, customized. And we need to bridge the gaps based on this, because we require to have very big land properties, and the territories that are urbanized, where most of the people live in the country, do not have land properties with these characteristics. They are very difficult to find. And additionally to this, the buildings in the health sector are not very plastic. And that is to say, they are not too adaptable to different needs that are evolving. And through time, because the benefits also change, the innovation moves very fast, and the buildings should be flexible enough in order to adapt themselves. And the buildings do not have criteria for environmentally friendly constructions and for the operations as well. And see that there are major gaps for the maintenance of this infrastructure. One of the most perceived problem is by the population is when the infrastructure is poorly maintained. There are many anecdotes to tell related to our PHC centers. So one big challenge will be to bridge this gap concerning the infrastructure, to do it fastly and in an appropriate manner. And we should have infrastructures that are smaller, inserted in the territories, and serving the most urgent needs, so that they can become an extension of the family health centers in the territory, and allowing to replace or to bridge this gap. The second line for progress is the effectiveness of care. The effectiveness of care means that what we do through the health teams should have an impact on the families, of the health related pathway of people on a daily basis. And these require different quality changes, some quantitative changes at the same time. But the core would be the qualitative changes, how we build together the health system with the people, and how people become leading actors in their health, and they take control of their health history throughout their lifespan. And additionally to this, this is at the individual level, but at the community level and social level, how we put in action the activity, and we develop the resources for the health system. So first of all, we need the training for the staff in order to understand that the relationship of the health team and the users should be rather horizontal. Unlike the vertical relationships that are part of the history in the healthcare system, on the other hand, we should have models of participation that allow to take advantage of the community assets and being at the service of people. Secondly, as James said, we also have the stratification of people, and we need to customize the care according to the needs of the population. We know that a low percentage of the people are those who require resources of the multi-morbidity patients, and these are the people where we should target the resources, and the less resources for people who have minor needs. And we're now targeting the resources there, and we need to come up with changes in the social context, in the social determinants of health, because if we don't produce changes there, we know that we'll continue to spread a situation that create more diseases than repairs or solutions of problems. So we have to focus on them, but at the same time, we should come up with social transformation, with increased participation, producing changes in the conditions of life of people. And therefore, the participation and the joint construction is fundamental for this line. And in here we have a quote of this process um, concerning the 40 years of the Alma Ata process, we had surveys and over 20,000 people participated in these activities. And in here I have a quote of a lady from the region of Bio Bio, and she says, the idea is these meetings are not just an additional meeting for conversation. These should be real discussions that are heard and that they can be a reality, because today this is very instrumental and we need to move forward with a more transforming kind of community process, transforming the needs of the population. And I will move now to this slide. The third major axis of transformation is quality. Quality for the PhD. And quality, I don't know, James, if we understand the same concept, but at least we are coining this as the base, so that the PhD is of quality and the same one for the whole country. And this um, ground is related to the monitoring, supervision that is relevant, so that the PhD is the same one all over the country. Here we have some relevant items, how we monitor the process. In Chile, we are putting this to the extreme based on outcomes, and we have million indicators and goals and some commitments of management or performance. And here we have over 40 conventions, 21 indicators, and all the instruments that we have for the PhD. And all of this is archipelago of indicators and indicators that are confusing for the health teams rather than being a guiding principle. And we have to think of this dashboard, and we should put it together with some criteria of transparency to do the accountability vis-a-vis the community. Another important element of quality is the human resource and how we're moving in order to establish equitable levels for the availability of human resources by macro region in the country. And we can see how this availability is quite uneven. In the blue line, we can see the number of doctors or physicians per habitant, and this is a problem concerning how we're distributing this personnel.
Another important challenge is how we transform the preparation of the staff to face these new future challenges. And to close, I would like to say that if we do not move ahead, the cost of not doing anything is having a system trapped without a purpose. Today, primary health care is bogged down with demands for management issues, but they're unable to have an impact. So having a system that treats diseases and not people, we have challenges to move towards treatments focused on people and their situation, to have a system that is inhuman and with lack of resolution and putting people at health, either because they do not treat or they overtreat, which is also a risk. And to close, say that what was shown by the Undersecretary at the end in terms of human evolution is, for us, this is how we're seeing it, as a challenge of our species. How do we build a care system that allows us to make this qualitative leap towards the future in terms of how we understand the relation among all of us in our countries? Thank you. Thank you, Bernardo, for illustrating these very interesting topics. It's so interesting to assess the history of the system in Chile and the progress made, and since institutionality is a key aspect for the future. We thank you. for the points made, and that the systems of the region still make these mistakes and challenges. We need transformations that are successful with policies that are appropriate, accessing universal health and not reproducing the inequalities. Thank you for your presentation. And now I'd like to recognize Jennifer Nelson, who's with us online. She's an expert on digital solutions for health and social protection division at the Inter-American Development Bank. Thank you, Antonia, and also I thank everyone for this excellent event. And I too would like to thank James, as well as the other speakers.
Voy a ahora compartir mi pantalla. Por favor, avíseme si lo están viendo, ¿ok? Y arrancamos.
We see your share screen very well. Thank you. I would like to begin my presentation, being a representative of a bank, with this phrase that I found on the health system in the US, which leads us to reflect if the bank works at the same as the health system, how long would it take to live in the connected world that we live in today? And why do I mention this? Because this analogy explains in a very simple way that the sector can still improve in its efficacy, quality, and sufficiency. For example, OECD, we know of a study that we published a few years back. If they had the same standards that were seen in the OECD in lack, efficiency, and public spending in health, we could have a life expectancy of up to another 4 years in the region. And also we know, returning to our analogy with the bank, we know that the financial industry is very advanced in digital terms, and the health system is already moving ahead, but we could do more in terms of using these technologies. And so I would also like to reflect on this, and that in the same way that we update our calculation systems, also our health systems require an urgent update. I will not get into this because a lot has been said, but I think that seeing this picture, we can all see some of the challenges that our health systems face. We have a population that is aging, and also we need to convey the cost of smoking and all these things that affect us outside the networks, and we're living in a post-pandemic world, but preparing for the future. So seeing this picture, I think that we could think of all the challenges that we're thinking of, and surely many more. But we do know that these challenges bring us to major issues in terms of the loss of years of healthy living. We have a sort of spending to support these people. Many of these cases, for example, a lot of cases of diabetes are not diagnosed, and those who are diagnosed are not under control. And after the pandemic, before we had a big gap in terms of mental health and how each one of these disorders can affect different population groups on account of the gender and age, and all of this has to be taken into account. So I like this very much, showing how we could play around with these variables in order to move towards a regional health coverage. If we're thinking that the larger cube is everything that we need to cover and the smaller cube is what we have today, we all agree that we need to invest more in this sector. But with what we have, we need to play around with these variables. What are we going to be able to finance? Who are we financing and with what services? And the way we're placing the cube, the idea is to achieve the maximum with the minimum. But together with the aggregate value that we have, which is the plus value of digital health when we're applying inclusive digital services. We have evidence that when this is applied well, these digital services can improve the efficiencies. We can cover more people and have more data to make better decisions and also see what services should be extended at the appropriate efficacy, and also to make decisions as to the services that we must ensure everyone has access to. So this is the digital aspect plays a key role in helping us to expand the cube, to achieve the utmost of what we have. And here, these are just some examples of challenges. Challenges that we live in with every day, and how the interventions could help us to resolve these challenges. For example, early detection. We know that we can, whatever we detect early on, this will have a better turnout and experience for the patient, and it would lead to savings. And also have more alternatives. We need to better detect certain diseases. Also, we have limited human resources. Also, we need to have greater training and increase the geographical coverage. Digital task shifting in order to empower and extend the sort of services that could be provided. We're going to see examples of all this, and also we're going to update things in order to break certain borders, frontiers, and work with telehealth. We also have factors where risk factors that could be reduced through several self-management. And so someone who has diabetes could self-manage their own disease. And perhaps one of the most difficult is coordinating the care. When a person that we're assisting may have access to other levels of care, and then they return to their home and they need to continue with this. So this could be done through exchanging information. But this is something I'd like to mention, and that all of these things, the bank, something that we're seeing with our partners at PAHO. This cannot be resolved merely through digital means. But yes, it is part of the solution. So we're seeing the need to have integrated structures, better human resources, and all these things that I mentioned now are elements that could provide digital tools. And all of this makes part of the overall package that we need to focus on. We all know that there are many different interventions that are needed. I work on this in more than 20 countries in the region, and everyone is doing quite impressive things. I've just selected some cases here, specific elements, but this is in no way is the only thing that is happening in the region. This is a study that we did together with the Ministry of Health, the University of Yale, and the bank to see how the digital networks could help out. This is an example that has shown the efficacy in terms of proving the counseling given by community health at family level. And so the health staff doesn't always have the time to deal with the needs of these families in person. But if it's done digitally, this could have an impact to convey the messages to these families in living in postponed areas, but also to improve the efficiency of the worker. In this case, an entire day's work was removed because they used to take the time to prepare their reports and notes, because now this is saved because it's all digitalized. And this benefits not only the families, but also the community workers.
Another example we're seeing from Mexico, where we were using the technologies such as artificial intelligence, is another example of tasks shifting. And in this case, we are working with certain apparatus that will take a picture of the eye, not only providing technology, but they send the picture to an eye doctor, and he can review all the different images and can be read by the expert. This is how we have been able to show that there can be an early prevention of blindness. And in this case, we have for Jalisco, Mexico, we have studied its impact and cost effectiveness, and the social impact is 3 to 10 times the investment. We can find it in, we will add a link for you if you can read, if you want to read more about these cases. I would also like to mention Uruguay. This is a very interesting example where we can see how we can empower people so they can have an active role in their health and save time. This has two-part intervention, an intervention that on one hand we are sending messages that are for people, especially, for example, women that need to take their PAP study. But we're not only motivating them for this PAP smear, but we are saving time, as prior to this application, they had to be in a long line to first get to know when they will get a date for their PAP smear, and this later on would be an online schedule. We're saving time for the people that needed to stand online and then have to return for a prevention activity that is not easy to do, but we know it's very important for their health. In Chile, we are also learning of the different interventions that the ministry is doing, and we would like to highlight a program of the digital hospital that many countries have been doing it. And this model of care, where it is very interesting, you in Chile probably can tell with more detail about this, but we were very impressed. And the idea is that you can always think and plan of a physical hospital with staff, budget, and others, but start thinking about this very same concept of a digital hospital by ensuring that those that can take care of their patients on a virtual basis whenever needed, makes us think about something very important to start thinking right now. Is when we have these comprehensive roles of the health area, we're thinking about geographical areas and how they are interacting in physical terms. Now that we have new areas for care, is where these physical barriers are brought down, we can connect people with specialists instead of transferring them to certain specific areas. We are now working on this concept and start thinking about the digital comprehensive systems. Another type of intervention as well, we can see in Uruguay, where we would like to also mention the importance that we can see in obtaining data, historical data that allows to exchange information from the public and private sector and do the follow-up of these people independently on how they are receiving their health care. We see the benefits of the health providers. They have seen using this system with better efficiency in their work process, better care, reduction of the tests and others. Everything that means better efficiency is a very clear example of how to obtain data and make us change the way in which we are doing things with the decision-making processes and the overall effect of our systems. These very same applications are being used in the Caribbean. As an example, you can see here the model of care in Jamaica integrated to the primary care system of chronic patients. They're already creating this very same perspective as Uruguay has of connecting all the public systems and the private systems in an interoperational system by providing the care to the population and let them know how to do the self-care activities like their weight and others. And as they arrive to their consultation, they can have all this information. This is being expanded throughout the region, and we suspect that the idea is it will be followed. And I would like to stop here for a while because it's a very interesting idea, and it's a change of paradigm where we all have to be prepared. This is an example that we're seeing exploring certain recent publications where we're seeing the need of thinking about a digital application and the same way that we are working in this area. In this case, to be able to treat certain mental diseases in Brazil and the United Kingdom and Peru as well, there is an application presented. The application has to have exactly the same thing as a drug, and a drug that will not be harmful. So these are some examples that have been done together with the Health College in the UK just to see how to improve their activities. Through a nurse, they can detect whether the person has a possible mental disorder and later on to provide them with the possibility of connect to a mobile or online platform that uh, that supports them through the internet. These are all guided systems that will show how efficient it is in improving the symptoms and provide something very important that we do not know, that we know we do not have enough people that are trained in mental crises that are being experimented at global level. Now, after seeing all these different panels of what is happening in the region, I would like to mention three very important elements. First, none of this, no digital solution to approach something as important as primary care and universal care will be resolved through a digital application. It is not a magic solution, but it is part of the solution. The second aspect is we are talking about digital transformation, but we should not forget that these are two different words. One, we're focused, sometimes we're focused in the digital aspect, and we forget that we need to transform processes, transform the way in which patients are receiving this information. We have to ensure that they are sent, that they want to receive the information. So it is not only to focus in the digital aspect, but as well as the processes, how sometimes we forget services to really make use of this to be able to say that we are transforming. Something we should not forget in general terms is services. This is something that we have to intentionally be inclusive when talking about digital solutions. Here we have an example that I would like to mention. It's from Panama, and it really stands out. As here in this example, a very simple menu that doesn't solve all these solutions, but it is a path in, or a step in the proper path. We are seeing that somebody is filling in their profile of accessibility, they can understand this digital aspect. It makes us think if we are expanding the access to the certificates of immunization, for example, or others, how do we make sure that everybody can access these type of platforms whenever needed? Here we have something that has been considered very seriously, where we have regional partners in the digital area. We have been working for more than 5 years, and something we have been able to see when working at national level and supporting the countries to understand their digital agendas, their strategic plans, and their digital health programs is to ensure that this will be inclusive. There is a policy guideline that has been published by PAHO and many of the groups that we have here, and we have to think how we are able to reach them when implementing a service. We have a digital channel. All this is very important, and very soon, I really hope that this year we will have a technical note that it will be published, plus new online tools where we will be able to understand whether a digital project will increase or decrease an inequality due to the different factors I just mentioned. This is an important announcement, and I would like to close by inviting you, as we are celebrating a call for action and the need to have a health connected for all people. And we have Dr. Barbosa participating and provide the need to have all the health centers, the digital health as determinant of health, and the importance of digital health that is interconnected, and to make sure that we can have the transporter activities. So I would like to thank you for your time, and it has been an honor to be here with you.
Muchas gracias, Jenny.
Thank you, Jennifer, for your interesting presentation. It is really interesting to understand the strengths of this activity in universal access. And I would like to express how important it is what you're saying, that going towards universal access supported by digital tools, you should consider the inequalities of the region, either in terms of health and the digital tools. And on behalf of people and health centers and the different territories, we do need an intent to work towards inclusion. Thank you very much for your participation with cases and specific examples that is considering people right in the midst of this. And thank you very much for the invitation extended to us. It will be a very interesting event. We would like to end or close the second panel, and please let us continue with the next panel at 2:30 on time, because one of the panelists is in a different time frame. Thank you very much.
Muchas gracias. Sí, la oportunidad de...
Buenas tardes. Vamos a dar 5 minutos para que todos puedan regresar a la pausa de almuerzo. Muchas gracias. Bueno, muy buenas tardes a todos y todas. Estamos retomando las actividades del taller. Agradecemos a
And well, we're resuming, and we thank everyone who was connected this morning, and also those who are following us by Zoom, and those, of course, in person in the hall. We're going to begin this panel 3, which is the last panel of this seminar, focused on articulation between the health systems and social protection, something that we also saw as a tangent in the previous panel. The role here, or rather the objective of the panel, is to highlight the relevance of the the social determinants of health and the relevance in terms of strengthening the connections between the health system and other components of social protection. And as we saw in the previous panel, with an emphasis on primary health care. And so to begin this panel, I am pleased to hand over to Zico Colombo, who is Director of the Health Division at the OECD and who will be giving a presentation focused on inequalities and how to address them by the connection with the social protection system. We thank you for your participation. We do know that this timetable is a bit late for you, so our special thanks to you, and thank you very much for being with us. Francesca, the floor is yours.
We're not able to hear you. No, we cannot hear you. Still not. Can you hear us? Yes. Okay. Maybe if you try muting and then unmuting. Otherwise, you could try to reconnect, maybe without the headphones, to see if it works. No, we cannot hear you. Sorry. Now? Could you speak? Yes, now. We can hear you.
Okay, so I took away completely the headsets.
Thank you very much.
I'm really sorry about that, the technical things. And I have a presentation, so it would be great if that could be projected for me. Waiting for the technical help.
Yes, it's being uploaded.
There you go. Technology is helping. Thank you so much, and I apologize I will be speaking in English, not in Spanish, but I'm really very delighted to be here, and sorry again for the little technical itch. I will be really talking about the coordination between health and the broader social protection systems. And really the main point is that if you want to address health inequalities, you need to act both on the health side, but also the intersection between the social protection systems and health systems. And if we can go to the next slides. I really would like to cover two main points in my presentations. It's really very simple messages here, but the first one has to do with the important link between socioeconomic inequalities and health system inequalities. And so how we see health system inequalities reflected and be a reflection of socioeconomic inequalities, but also how this link is very much vice versa. And so the message being that obviously addressing health outcomes and health outcomes inequalities requires working through both the health sector and the broader social system that surrounds the health sector. And I will then be looking at some of the action that can be done to address this. So if we can go to the next slide. The very first part, I will be showing you some data looking at this two-way relationship, and it's probably nothing really that will surprise you in any ways. But if we go to the next slides, the very first considerations here is that when we look at health gains, they have been increased over the years. On average, we have seen in the past 20 years or so, health gains in the Latin American countries in the order of 3.5 years life expectancy, but those numbers have not been shared equally. And this graph just shows from some Latin American cities the spatial distributions of life expectancy at births that very much differ. So different parts of a country or of a city have different life expectancy, which typically correlates with areas and pockets of poverty and socioeconomic inequalities. Similarly, if we go to the next slide, we have a similar picture that we have socioeconomic disparities that reflect and both drive health inequalities. And this can be seen simply in this graph, which shows under age 5 mortality by education level and by income quintiles. The story is very clear. Obviously, those who are more disadvantaged, either because of poor education background or because of coming from poorer quintiles, tend to show a significantly higher under 5 mortality. And similarly, if we go to the next slides, we have socioeconomic inequalities which start from geographical disparities, and they're reflected in differences in access to healthcare. And this graph is coming from the publication Health at a Glance Latin America, that shows really differences in access to basic education in rural and urban areas across different countries, with some countries showing greater inequalities than others. And the last slides to illustrate these points, which I had, is really specific to Chile. And here it looks at how socioeconomic disparities are reflected into inequalities in risk factors, in access and health outcomes. And so, for example, if we look at differences in health outcomes by socioeconomic determinants, those are very much significant, no matter whether you look at health outcomes and how they vary by education level, or also access to care and how that vary by socioeconomic and income. So that's all, it's obviously quite clear and known. But if we go to the next slide, I think it's quite important also to highlight the fact that there is a two-way relationship. It's not just that people from low socioeconomic groups will have poorer health outcomes, but also that ill health will affect the capital formation throughout the life cycles, and therefore contribute to poor economic and labor market outcomes. And that starts from early age. And this notion of life course is very important. The disadvantages and inequalities built from early age with young children, obviously at birth, which also because of poor nutrition, they have difficulties in cognitive developments and educational outcomes. That translates into poor developments into young adults, which translates then in poorer employment prospects and opportunities, and ultimately in late in life translates in lower pensions, lower economic possibilities, poorer health, and so forth. So this link, it's fundamental. If we look at the next slides as well, it really shows how poor health also damages the labor market outcomes of individuals because of unemployment, absence from work, presenteeism, and lower wages. And the message here is really that addressing that complex two-way link requires a very strong coordination between the action which is done in the health sector and what is done in the social and economic sectors. And it's really by addressing those linkages and having coordinating action that we can make a differences on and addressing those links between the sectors. So with that in mind, what can be done? And if we go to the next slides, I will be now talking about, going from more the focus on the health sector to the broader focus of some of the action which are important to be done. And the first one, if we go to the next slide, is I presume what you've been discussing here today, and it's the importance of having strong health systems which are clearly centered on primary health care. Why on primary health care? Because primary health care is actually the more equitable way of having access to health care. And normally when we look at outcomes as well for individuals across different socioeconomic groups, they tend to be lower in primary care. So primary care really has a function of reducing those socioeconomic inequality. Unfortunately, it is not what is prioritized in health system. And this slide shows the share of spending on primary health care relative to total health spending. And as we see, there's an average, depending on countries, around 10–15%. So it's really very small part compared to what goes to hospital sectors. It's also quite important to raise the performance of primary health care. That's very often not as high as one would wish to be. And one important area, if we look at the next slides, is also the measuring of the outcomes in primary health care for individuals that receive basic care in primary health care. And thus far, across countries, we do have very limited, if any, information on outcomes as reported by patients in primary care. So this slide just illustrates what we're trying to do at OECD to fill the gap, which is an international survey called Paris Survey on patient-reported outcomes and experience of care in primary care. We're going to have the results of this survey, which includes a number of Latin American countries, released towards the beginning of next year. If we go now to the next slides, and that's my second point, going from primary care, we go now to the intersection between the health systems and the broader socioeconomic, other wider sectors. And I think the point here is really the importance of better integrating health and social services, which has clear advantages in terms of access, cost, and quality. Quite clearly, at the moment, we have a situation in which there is strong care fragmentation, which is particularly a problem for individuals with complex health needs. Those individuals have usually a combination of health as well as social care needs, whether it's linked to poverty, whether it's linked to lack of appropriate accommodation and housing, whether it's linked to poor educations and so forth. And clearly, working through those complex care needs does require looking at health and care services in combinations. So that could mean by looking, for example, at the healthcare services, starting to integrate then by having a focus on data integration, that really try to look at the pathway of an individuals across different parts of the sectors, but also looking at the integration of health and other social services with a particular focus on vulnerable group. Now, if we go to the next slides, the question is like, are we really there or not? And actually the reality is that very often this is not the case. There are many different challenges in integrating health and other social services. They're linked to lack of a legislative framework that somehow links the two sectors, and that requires, therefore, acting on strong governance looking at the legislation systems and how that permits a stronger integration across the sectors. Very often there are different financial flows for health and social services, but there are interesting experience in countries that have tried to create a pool addressed, for example, to specific populations with specific needs. For example, people with housing and health problems, or people with long-term care issues and needs. So this idea of trying to have more financial integrations, it's an important way to bring that health and social services together. The notion of patient-centeredness translates in also measuring better the outcome from patients, which can be outcomes that are the results both for health, but also of social action. And particularly important is also to have data strategies, the possibility of linking data sets across also health and social services in a more complete fashion. All of this obviously also requires better development of evidence, particularly on useful practices that we start to see in some countries. So if we go to the next slides, the third thing that needs to be done is really addressing much more the social determinants by having a focus on prevention and public health. And this slide is just, it's an illustration. It shows how a strong focus on prevention pays, because it costs relatively little, but it delivers a lot in terms of returns on investments. And these graphs illustrates the return on investment for each US dollar which is invested in interventions to tackle overweight and obesity. And no matter whether we look at more communication-related interventions like food advertising regulation or food labeling, mass media campaign, or we look more at other type of interventions, including in terms of educations or in terms of the fiscal package as well, prescribing physical activity and so forth, we see that there are very positive returns on investments from all of those. The trouble, if we go to the next slides, is that very little is spent on health prevention and on public health. Only 3% of total health expenditure. Very often also interventions do not focus on the most cost-effective measures. So there is a disconnect here between where we can get the best gains and where the money is really spent. And the first area, and it's my last area that I want to mention to you if we go to the next slides, has to do really with tackling determinants of health and health inequalities by looking way beyond the healthcare systems. Here, this slide shows how life expectancy gains are can be associated to an increase of, say, 10% or 10% change in the main determinants of health. So if you have a 10% change in health spending, you can expect an increase in life expectancy. So that's a good news. So if you have good spending, obviously with a focus on primary health care and in prevention, you can expect that you will have increases in life expectancies. But equally important, there are strong returns that come from investing in action that improve income from individuals with poor health outcomes, that try to raise the economic, the education perspective, and they obviously address unhealthy behaviors like smoking and alcohol. So if we go to the next slides, if we want to really make a difference in terms of inequalities and health outcomes, we need to rebalance a little bit the picture in a way. I mean, the policy responses very often are not balanced across the sectors. So they would look at some of the determinants of health, but not necessarily at those income and social factors that have a very important bearing on health outcomes as well, whether they're related to education, health-seeking behavior, unemployment, poor working conditions, or living conditions. And so if we go to the next slides, my strong message, if we want to have, maybe if we go back just one slide, if we want to have a better result, we need to have policy response that is better balanced across those sectors. So delivering the best returns in terms of health outcomes could come by focusing on the health sector alone, but it could equally come by investing in things like housing, in social policies, and so forth. And it's quite important that that integration and addressing those issues that could be legal, could be financial, could be for lack of integration of data, it's very important to address those if we want to make a difference. And with that, I stop here. I thank you very much, and apologies again if, for the little technical issues at the beginning. Thank you very much.
Thank you very much, Mrs. Colombo, for your very interesting presentation. Quisiera destacar.
I would like to highlight that this presentation was very clear in effectively showing the need to articulate health issues with other sectors. The evidence shown here is very interesting, as well as the importance of prevention and how, even though what is important in terms of prevention and the importance of the social determinants of the health results, the level of investment in those areas is not enough yet. So thank you very much for your presentation and for connecting at this time of the day from your country. We will now offer the floor to Olga Toro. She is assistant professor at the School of Public Health at the University of Chile and director of the Collaborating Center of Pahahu for Development, Training, and Research in Mental Health. And she has a presentation and comments to our previous presentation. Thank you very much, and you're welcome.
En primer lugar, muchas gracias.
Thank you for the invitation, and so congratulations for including the mental health dimension as a concept that we use today with regard to health. And that is a topic that in all recent publications and opinion surveys appears as a priority for the population. I wanted to comment, speaking of Francesca's presentation, 4 ideas as to why mental health may provide interesting elements for this thought and analysis on universal coverage and the social determinants of health. 4 ideas. The first is the case of mental health as a social phenomenon. Mental health is interesting to observe, first because the concept has evolved in the modern era, mainly based on new evidence in that mental disorders do have a cure and not seen condemned to madness. Current trends show that technologies available allow outpatient care, and so therefore the role of primary health is central. The second aspect in this change with regard to mental health is thanks to the user movements and that advocate in favor of the rights of people with mental health. And just speaking of the inequalities in health, gathering the evidence such as how people with schizophrenia die early on, 2 or 3 times more often than the general population. We did a study a few years ago in a control population in a metropolitan psychiatric service of around 800 people. None of the women in this control had ever had, for example, the PAP test. And so the natural risk of suffering a cervical uterine cancer and uncontrolled for this sort of cancer, this was a high-risk population group. And inequity, because the situation is absolutely foreseeable, preventable, but it tends to happen that people within the health system as such, people with mental disorders have a different treatment. The example given by Francesca in terms of certain social factors, social determinants such as work, school, and so on, and themselves are not only the effect of poor health service, but also the origin and determination of poor mental health. And so this first idea, and that it has been the health systems as such that have acted as intermediate determinants of inequalities in access and quality when we're speaking of mental health. The second idea is these new concepts in that mental health is no longer madness, but the state, the condition when people are able to relate to the world in a satisfactory manner, relate to others, and healthily with themselves. This leads us to think of new ways of responding to mental health care. And so the new care models called community care in the countries of the Americas have, at least in the intention of their public policy, have wanted to ascribe to this model, which is also furthered by multilateral agencies, essentially WHO and PAHO. In Chile, in the 90s, with the entry into democracy, the diagnosis for the population in terms of mental health was around 3,500 beds in psychiatric hospitals, mainly in two regions of the country. That is totally installed excellent model, which for the level of development that we have today is unexplainable. And today the scenario is very different. We have primary care that has included mental health programs at all health centers. And so this has implied, for example, including psychologists in primary health care level, but in the 90s that was unthinkable, a total luxury. But today it's unthinkable not to have a professional of this type in primary health care. With this idea that having a highly promotional, preventive approach of mental health. However, there is a study in 2005 assessing once the first two national mental health plans were implemented, what has been the role played by psychologists in primary care? And close to 70% of their activities are intrabox in a classical model of curative treatment. And so this needs to be reviewed, and that is what we have been studying. What are the incentives? What are the conditions so that after having made the effort as a country to include more comprehensive teams in mental in healthcare, that they move towards a model that is really permeated by this model of social determinants of health, mental health. In the countries of the region, according to the Mental Health Atlas published by WHO, 70% of resources, that is, the proportion of the budget assigned to mental health in the region is no more than 2%. But within that limitation, around 70% is still focused in psychiatric hospitals. And this goes against what we have been talking about today at this seminar. And the presentation by Francesca, in that the situation today has been permeated by the systems that we have set up precisely for universal coverage. And so payment mechanisms, I like to see, Francesca, the means of payment. Speaking of my doctoral research, and when I study the impact of payment mechanisms in terms of community care and mental health. And in general, we see that these transformations of the health systems towards models that aim at considering these social variables and exposing the promotion and prevention of this. In the case of mental health, these reforms were made depending on reforms to the health system in general, and there's been scarce consistency in terms of reforms to the psychiatric systems, and so it has been limited financing systems where we still have the curative logic and focused on medical intervention. And so this is, of course, not helping. The incentives are not there, and so the OECD has a couple of very interesting publications warning that in the case of payment mechanisms for mental health, we cannot focus on what is determined by the diagnosis, because we need to take a look at the person's condition rather than the payment based on diagnosis. And so it is clear that we need to have social protection systems. And so the third idea for mental health is social protection before and after. Social protection before, first, because to safeguard the mental health of the population benefits from surroundings where there is social security and material security. That is, material security in terms of meeting their basic living needs, and social security in the sense that the settings are free of violence, with the ability for social cohesion, of community activity, social activity. And we know that in the countries of our region, we still need to do a lot in this sense, this sort of security. There is a population group that will benefit from promotional and preventive strategies based on social contact. And the evidence is extensive in terms of self-help groups, social organizations, and recently greater evidence on the inclusion of a peer work. That is, persons who have been diagnosed with a mental disorder and that may be trained in peer work precisely to work at territorial level, or the inclusion. We've done, for example, a study with Quality Right, which is a WHO instrument to assess the quality of mental health services. And this is interesting because the assessment involves the users of the services, the patients. And so here we see how there is an imbalance between looking at the social aspects of housing, work in terms of integral care in comparison to the more biological dimensions. And so here there is a challenge because it's not easy. The administrative structures of health systems, it's not easy to include these approaches and include administrative questions such as how do you hire workers, peer workers, if they do not have a professional degree? How do you regulate what they're doing? In general, the health codes in our countries are very old-fashioned, and modernization is not quick. And then social security afterwards for those people who do have mental conditions and that have this has led to some sort of mental or psychosocial disability. And so housing strategies with support, work with support, and today Chile has interesting laws aiming towards inclusion of disability. But it has been far more fruitful, this inclusion, in the case of physical disability, sensory or visual disabilities, not so in terms of psychosocial disability. And evidence shows what we think before, that we need to create social enterprises which were employment places, basically where the workers were people with mental disabilities. But what ended up happening is that the work was very precarious and in a direction very different to labor inclusion as countries speak of today. And we promote normal work systems where these people with disabilities can be included with special support. And lastly, the fourth idea, in terms of these recommendations made by WHO, I think it is symptomatic, beautifully symptomatic, that there are two world reports by WHO on mental health. In 2001, New Knowledge, New Hope. It's not by chance, the title. And the big discussion there is that we had sufficient evidence to bring mental health issues to the territorial level, community services, community centers for mental health at territorial level, include mental health in the general health system, and no longer merely psychiatric hospitals, because the trajectory could be towards recovery, total recovery, full recovery. It's a very interesting study that shows that in the case of schizophrenia, 50% of people do evolve totally, which is what 30 years ago was unthinkable. And today we have the World Report of 2022 on transforming mental health for everyone. And the goal is to achieve this universal coverage. And ultimately, this implies reorganizing the settings that affect the mental health of people, and there is the social determinant, and strengthen the response in terms of mental health integrated to health systems at these primary healthcare centers and also the community mental health centers. That is what I wanted to add. Thank you very much. Well, thank you, Olga, for those very interesting comments. It's interesting to see how the concept of integrality is implemented in a specific space of health, in the case of mental health, and how it is so clear to see the impact of social determinants on health or the social determination of health in this particular area. I also believe that what you have said in terms of the inequality of the results in physical health, how discrimination linked to mental health is also reflected or also leads to inequalities in the physical health. So thank you for that presentation, and there are so many other interesting points that you made, but we must now move on. And before recognizing the next speaker, I would like to remind you, those who are online, that you can answer the survey, and those in the hall, there is a QR code that you can scan to please answer the survey to assess the seminar. And so now we would like to hand over to Romulo Paez de Souza from the Osvaldo Cruz Foundation, and the floor is yours.
Good afternoon. I would like to greet Maria Luisa Mariño and to greet all of you. I am speaking from New York, and I will be sharing my presentation. I will be speaking English as the thoughts or my thoughts come from articles that have been published in English. Let me check. This is not how we can really see it well. Yes, we can see it.
So I will switch the language in order to make that easier, because as you can see, I wrote in English the slides. So I'd like to start considering the context of Brazil, the political and philosophical context when we think about the inequality, and in starting from the experience about the pandemic. But previous to that, the context of Brazil was pretty tough. So in that sense, because that time, and still now, we are isolated by economic deficit and austerity policy that is changing. But also, As a consequence, what happened, it was reductions on public policy offers, and that happened in many countries, as CEPAL has studied in others. And also, there was combined with limited capacity of the families for fulfilling their needs due to unemployment, low quality jobs, reductions on social protections as consequence of this austerity policy. But also some philosophical aspects that I like to also to raise in relation to mistrust escalating political conflicts, and lack of investment on public policy, including social and environmental policy. And also something that was terrible and is still on in this polarization of the political context, not just in Brazil, but in all other Latin American countries, open promotion of anti-democratic acts and restrictions on human rights by important political leaders. In that sense, compromising the solidarity and the notion of an integrated nation. And that is important because the basics about our model of social protections, social protection is based on social solidarity, as it is in other countries. Yeah. And just the last philosophical comment is the rise of solipsism. Basic is the people thinking that what they think is it's enough for sustaining anything. So if they think that the planet is not round, it's enough because they can confront anything just based on their own perception about the world and the other aspects. So, and also the decline of the legitimacy of the science, political institutions, state, political parties, and the rise of sectarian evangelism and the cult of the violence as an effective way for solving problems. And I'm talking about violence, physical, legal, or digital. So that context is what is happening in Brazil. Still, we are in that transition process, and in some cases, will take long before we change that scenario. In that aspects, many what is being doing now in the Brazilian public policy is just to recover that sense of predictable state, that connection between the state and science, that connection between the state and good practice in public policy management. So it's about recovering. And that is very important in the sense that how can we achieve some evolution or some development of the public policy while we are still recovering. And what is interesting, that combination about austerity and reduction in terms of philosophical reduction in terms of solidarity, we have this combination, and I published a paper not very long ago about the two dimensions of this. One is individual and family, which is below, and up you can see about this society sphere, about what kind of reduction, what kind of restriction we faced as a consequence of austerity policies. So we have this combination in the social terms, this reduction about investment, reduction about the offer, and in the individual and the family dimension, what happened about the restriction about income and also public policy transfers or conditional cash transfer. What happened in Brazil about many confused decisions that in some way produce a lot of problems in our main program for social assistance in Brazil. Anyhow, so the combination of the two dimensions produced the increase in terms of morbidity and mortality. But I'd like now to finish these comments, bringing to you some aspects related to policy for fighting inequalities, because we've been very competent in order to point out inequality, inequity, and showing how unequal can be societies and can be considering the countries and within the countries. But little attention has been paid about how to produce public policy to mitigate or to reduce that kind of contest. So I'd like to call your attention for some recommendations. The first thing that I like to focus is we need a consistent and sustainable long-term strategy that indicates a resilient policy with the capacity to go beyond electoral cycles and ready to respond to economic and political shocks. That paper was written previous to the pandemic. It was published after, but it was written previous to that. It's important that that approach should be based on social justice. It's important to have coordination institutions because health inequality policy requires a large number of actions from different areas and levels. It was mentioned in the previous presentations. The coordination of different actors from different loci and interests requires a specific space of horizontal and vertical coordination with mandate and a capacity for easing divergence and identifying the best cost-effective solutions. That happens permanently. To integrate policy, we should be able to deal with conflicts. They may be legal, political, or even administrative, different conflicts. Also, development of technical capacities. A great limitation for implementing any action is the lack of qualified professional for implementing the adequate procedures. In developing countries, that is aggravated by high turnover of the limited trained personnel as a consequence of precarious labor contracts and low incomes. So we have a huge inequality in relation to qualified personnel across the countries. So it's important to have clear policies for holding people, especially in small cities, in remote areas. Social participation. That comment is strongly associated with the long-term sustainability of policy and programs, and it will be further explored in the next session. But in that case, I just like to call your attention for that. We, in the scientific literature, it's not very clear if social participation improves the quality of the programs, of the service. However, the survivorship about the political legitimacy of the programs can be increased if social participation is strong. So that's why, in terms of the designing and implementing social policies, they come as an important part, important component on that. Also about promoting social development, restoring the broader dimension of the concept of development in order to integrate the excluded population into the national and local economic and social dynamics. Many countries, it is the case of Brazil, but it's not just in Brazil, we have many municipalities and communities, they are very dependent from transfers, state or national transfers. And it's very difficult for many municipalities to change the economic agenda because in many cases they are very based. In the case of Brazil, of commodities, can be mineral, can be from the agriculture. So in that sense, to diversify the economy, it's a very important approach. However, that's not an easy task. So it depends very much how the government can manage the transfers in order to keep the economic activity, especially in the very small cities. They are far from these commodity activities, commodity production activities that we do have in Brazil. Promoting equity is using public policy to reduce unjustifiable difference and fighting discrimination, reducing the poverty gaps faced by minority groups such as Black, Indigenous, and traditional populations, generating opportunities, human capital development considering gender, place of residence, and cultural context, improving quality in delivering of public goods and service. The main deficit faced by vulnerable population is lack of access to quality public service. I'm talking from Brazil about some context where we have developed pretty much many public policies. However, we've been much more competent in extending the coverage rather than to offer good quality service. And finally, developing sustainable policy. The endogenous and exogenous factors that can affect the programs and policies, sustainability, should be considered while developing the model. So my point here is we need specific policies combining with universal policies to address inequality, health inequality, in combination of social inequality. And it's very important that that be part of the goals of the nations to have specific goals for fighting inequality. Universal approach is very important. Improving the quality of the service is very important. However, it's important to have specific targets and to fight for that. Thank you.
Muchas gracias por Thank you for your important comments related not only to this panel, but what we have been discussing and presenting in the previous panels. And just to highlight some of many of the points that are very interesting and probably always agreeing with what we have been discussing, it seemed very important what you just mentioned in terms of the need to have policies that have sustainability throughout time. It is something that we have been discussing during coffee break, during lunch with some of the participants, and be able to take it not only from the current administration, but it should become a policy of state, if you wish. Also, integration and the importance of articulating it with other sectors, how this will require conflict resolution. Of course, we cannot think that there will be no conflicts, but we would have to look to solve this and to have policies move ahead, and as well to consider what you were mentioning in terms of universality. Here from ICLAC, we are promoting the universality sensitive to differences. This is exactly what you were mentioning, together with establish a guarantee towards right for all populations to have specific actions that are aimed at those groups that need a right of the rights. It is very important what you're saying to be able to consider inequalities and health. Thank you very much for your participation and the very interesting comment that you presented. We will now hear our next lecture. Please, I would like to remind you that on your screens and here on the room, with your headsets, you can use interpretation English-Spanish. Our next lecturer is Joan Smith. She is lecturer at the University of the West Indies at Mona, Jamaica. Thank you, Professor Smith, for being with us.
Hello, thank you very much. Are you hearing me? Are you able to hear me?
Yes.
Okay, great. All right, so let me just start my slide show.
It is not on the full screen.
Is it showing now?
Yeah, yes, thank you.
Okay, and tell me if you're still seeing it in the appropriate view.
Yes, still on full mode, yes.
Okay, great, thank you. So good afternoon, everyone, and thank you for the opportunity to present. And I am Dr. Joanne Smith, a lecturer at the Epidemiology Research Unit at the Caribbean Institute for Health Research at the University of the West Indies in Jamaica. So today I'll be speaking about Reach Up, which is an early childhood parenting intervention. Now we know that more than 250 million children under 5 years old in low and middle income countries are estimated to be at elevated risk of not achieving their human potential because of stunting or exposure to extreme poverty. Falling behind so early in life can result in negative impacts on physical, cognitive, and emotional development, education outcomes, and earnings throughout adulthood. Brain development is most rapid and vulnerable from conception to 5 years of age, and early environment and experiences are critical. Optimal brain development expects and depends on needed experiences in their environment, and the brain is highly sensitive to adversity. Biological and psychosocial risks can lead to deficits in brain structure and function, and in cognitive and social emotional development. And some of the previous speakers discussed the importance of mental development and brain development. So early life experiences are key factors for equity. And we also discussed equity earlier in the presentations as well. Policies and programs that are implemented to promote early childhood development can reduce inequality and facilitate gains from later educational and societal opportunities. So there is an urgent need to scale up programs and increase investment in early childhood development as a foundation for health, social, and economic outcomes throughout the life course. And integration with existing services provides one such opportunity. The last decade has witnessed an increased prioritization of early childhood development. Target 4.2 of the Sustainable Development Goals calls for all children to have access to quality early childhood development and care by the year 2030. Programs which encourage early mastery of a range of cognitive, social, and emotional competencies make learning at later stages more efficient and therefore easier and more likely to continue. Rates of return to human capital investment in disadvantaged children can change over time. The declining figure seen on your screen here plots the payout per year per dollar invested in human capital programs at different stages of the life cycle for the marginal participant at current levels of spending. As you can see, investments earlier in life have the greatest rates of return. The Lancet series on child development highlights the need for early child development interventions to be integrated into government services. In 2018, the WHO launched a nurturing care framework that places responsive caregiving and opportunities to learn for children 0 to 3 years as critical components of care for young children, and calls on government to provide necessary support and services for families who are the primary providers of care for young children. So this child development focus requires that we have adequate nutrition, access to healthcare, protection from violence, responsive interactions, and opportunities for early learning. Nurturing care is fostered by a supportive environment where we see families need support from their communities and from government programs and policies that can strengthen their ability to provide nurturing care in the home. The figure that we see on the screen describes how these sectors interact and the need to implement policies at the national level to ensure that this is the case for each child. So now I'm going to speak to you briefly about the Jamaica Home Visiting Intervention, which was started in the early 1980s. So in this intervention, the first efficacy study was conducted with stunted children from low-income communities. These children were randomized to 4 groups: children who received supplementation, which is a milk-based supplement; stimulation, which I will describe in the next few slides; both interventions, which includes body supplementation and stimulation; and the control group. Those children who received both interventions had significantly higher impacts in developmental quotients than the control group after 2 years of intervention. And surprisingly, at the end of the intervention, they caught up with their non-stunted peers, especially those children who received both interventions. At the end of a 2-year trial, each intervention benefited development, and the group that received both interventions, both the supplementation and the stimulation, attained developmental levels of the non-stunted group. So we follow these children from childhood at age 7 and 11 years and adolescence at 17 years of age. And we saw that the benefits from supplementation faded, but the benefits from stimulation for cognition were sustained. And over time, we saw benefits for education and psychological functioning emerged. At 22 years of age, for those children who received the stimulation intervention, there are benefits to education, where they had higher scores in reading, maths, and general knowledge. They had a higher grade level attained compared to the controls, and they had higher secondary level examination passes. We also saw benefits to their mental health, where they had less depressive symptoms, better social skills, a reduction in violent behavior, so they weren't getting into as many fights or any confrontations. And they also had increased wages, almost 25% more than those who were in the control group. So we followed these children at age 31 years, and that was about two or 3 years ago. And those children who received a stimulation intervention still had benefits to their IQ, where they had greater IQ and cognitive flexibility, reduced depressive symptoms, increased grit and conscientiousness, lower substance use, and lower risk-taking related to health and work. So the benefits continue even into adulthood. So now I'm going to some details about the reach of home visiting intervention. So in 2014, Grand Challenges Canada provided funding to manualize the Jamaica home visiting intervention, and Reach Up was created. So Reach Up is an early childhood parenting program and is an innovative, comprehensive training package based on the Jamaica home visit program. The aim of this package is to increase the capacity of implementing agencies such as non-governmental organizations and governments to deliver effective parenting programs and facilitate scaling for children 0 to 4 years in low and middle income countries. So the Reach Up package contents included adaptation and planning manual, which helps to inform the program implementation processes. There's a toy manual, which provides step-by-step instructions for the making of toys from recycled materials. There's a weekly or fortnightly curriculum available, which provides a guide for the visitors to help with conducting the visits with caregivers. We also have a training manual that provides information for the interactive training workshops, which are conducted to train staff who will deliver the project. And we also have a supervisor manual and handbook with an observation checklist to help with maintaining the quality of the intervention. Key features of the intervention include a parent and child focus. We have an interactive play session with the parent and child to build the parent's ability to promote development through playful interactions. We have a structured curriculum that uses play and everyday activities to introduce concepts and language, and the activities from the curriculum are matched to the child's ability, where the activities are challenging but not frustrating to the child. And play sessions use homemade toys, songs, local songs and games, language activities, and picture books, which reflect the natural environment that children are exposed to. And the parents are encouraged to continue the activities and integrate them into their daily routine. So here I have an example of some of the toys that are left in the home. So we have puzzles, we have some plastic toys, which is a stacking toy, a shaker, some books, blocks, crayons, and these can be made from recycled materials or materials found in the home. So it can be organized as a weekly or 2 weekly home visit, or can be center-based, which will have small group sessions. The visitor would demonstrate the play activities and involve the mother and child in play, and encourage the mothers to practice the activities and continue these in the following week. And again, the curriculum is arranged in developmental order and adjusted according to the ability of the child. So just some things that I wanted to just point out about the Reach Up model and how it supports quality at scale. So when you want to scale up the Reach Up program, because we have an adaptable curriculum, this provides activities to strengthen the child's overall development, and it can be modified based on the child's ability, so it's adaptable. Low-cost toys that can be rotated. So inexpensive toys can be created from recycled materials and can be left at the homes and reused at later visits. It's a scalable structure. The program maintains consistent focus on supportive supervision while maintaining quality controls and adaptable to a group format. So it can be adapted for use in small group sessions and in childcare centers, depending on the need of the organization or the implementing agency. So I just want to give some brief overview of the Reach Up program, which has been replicated now in 19 randomized controlled trials within 9 countries. So we have a list of countries here: Jamaica, Bangladesh, Colombia, India, Brazil, Zimbabwe, China, and Peru, and Madagascar. And I just wanted to give some information about the impact of the adaptations using the Jamaica model. So this slide provides summarized information on the results of some of the evaluations of programs based on the REACH-UP model. The first is a study by Grant and McGregor, is the original efficacy trial, which evaluated the impact of the intervention in stunted children from low-income communities and showed large benefits. The first replication in Bangladesh similarly evaluated the intervention in undernourished children using weekly home visits, while the second used small group sessions delivered at health clinics. In the two studies in Colombia, the intervention was delivered linked to existing services. In the first, a cash transfer program, and in the second, through the family home daycare program. The study from India, compared the home and group visits and showed both had similar benefits. And finally, the evaluation from Peru is from the National Cunamas program, which is a home visiting program, and the treatment effects range from 0.15 SDs to 1.3 SDs. So for the ongoing programs, we are implementing REACH-UP with the International Rescue Committee, with Syrian refugees in Jordan and Lebanon, the Rohingya refugees in Bangladesh, in Guatemala through the Child Fund, in China through the China Development Research Foundation, in Bangladesh through the Ministry of Health, and in Jamaica through the Ministry of Health and Wellness. So just briefly, when implementing the program, again, REACH-UP provides curricula and materials which can be adapted to the user context. So here we have 3 different dolls, some 3 different implementations, and we also try to include cultural practices and identify materials which can be available in the particular site and can be adapted for the program. And setting up the program includes 4 main steps. Initially, we identify and create the implementation team, source the play materials, conduct a training workshop with key staff, and then provide tools for monitoring the quality of the implementation. So just want to state the key features of the REACH-UP program for public policy. It can be integrated into an existing system, example, health or social policy. It is adaptable to the context. So the mode of delivery can be home visits or group delivery. We have a structured training program, structured curriculum, which provides better support for visitors and facilitators. And we also include monitoring and evaluation with tools for supervision and mentoring. So if for more information, I have our website there and email addresses. I just want to thank you very much for your attention. Thank you.
Thank you very much, Professor Smith, for your very interesting presentation. Now, and very similar to what Professor Toro did, she is showing us a very specific example of intersectorial relationship, how this establishes benefits at health level and in other areas of development of people. This additionally can be seen a long time. It is not only an intervention that is just left in a very specific time of the life cycle, it can also be observed throughout a lifetime. So thank you very much for this interesting presentation. We will now be closing this third panel, and I would like to highlight only 3 elements that I believe are quite interesting to obtain from Francesca Colombo's presentation and the 3 comments right after it, which is the importance of integration. Integration understood from different perspectives, from actions, access. Also, an important element was the integration of data, which I believe is a very important dimension, very interesting to continue exploring, and how this can be generating areas for prevention and promotion, as it was very clear with the presentation of Professor Toro's presentation and Professor Smith's. And other elements as well that reinforce this idea of reaching more integration between the social protection systems and the health systems. Another element that was uh, seen from the presentation of Professor Romero and Professor Toro is the centrality of the PHC in people and populations. This was something that was stressed by Dr. Martorell in the co-building of the health systems, and all this goes together with the idea of increasing investment in PHC to overcome inequalities in health and other inequalities. So thank you very much to our panelists, for those online and the ones that are here. It has been a pleasure to be the moderator, and I will offer the floor to Raquel Garcia. Good afternoon to all. I have been able to be in this seminar. It has been a tremendous privilege to be here and thus close this session of this international seminar, Inequalities in Access to Health, the Centrality of Primary Health Care to Advance Towards Universal Health. I believe this seminar has been able to strengthen the centrality of health for sustainable development in its different axes or pillars. It is very important to see how we still acknowledge the structural elements of the region, not allowing access to health. Many countries in Latin America and the Caribbean are committed to this ethical element of placing health right in the midst of the discussion. I would like to offer the floor to the representatives of the countries that are part of the project so they can present their last comments. I would offer the floor to Dr. Emma Montefiore, Vice Minister of Primary Health Care Center of the Public System in Guatemala. Thank you for this opportunity. Evidently, we all win when we are able to share experiences and we're able to learn from them. With regards to PHC into moving towards access and coverage of health to overcome inequality, we can see how this joint effort between agencies or departments or interinstitutional cooperation will favor any actions in health. But furthermore, it makes it evident how investment in these interventions are able to make impact in human capital in the mid and long terms. But we are also winning as there is a benefit for the person, for the family, and for the community. Something else is that it is a two-way investment. The institutions that invest in these interventions provides them with transparency, and this becomes an accountability exercise as the community, the society is participating and is needing those responses through policies, investment in social protection. Well, that is what I think is very rich. And thank you for this possibility of sharing experiences and for learning. Thank you, Dr. Mutufat. I think we do agree with this bi-directional character of in public health. And I would like also to offer the floor to Mr. Raciel Ramirez from the IMSS of Mexico. Well, Mexico in this case has made structural changes in the health system that is being established. First is a federalization of services, which is really unifying health care in the country and thus have only one health institute and obtain this universality. I have been carefully hearing all of the presentations and the experiences of all the different countries, but moreover, to get to understand how they have been able to see the different problems and how they have analyzed and how the different health systems can be working in is what we are seeing in Mexico. I think it is important to be able to show what we have been able to do. We are still fine tuning this process. This is not a process that is in the short term, it is a long term process. And any of our experiences in the different countries that we have heard from the different experts, well, we have to continue contributing in, in improving this knowledge and health. Thank you very much. Thank you, Mr. Ramirez, for your words and for the commitment in all these areas. Before offering the floor to the Director of Social Development Division, I want to mention we have had more than 250 connected, a part of those that have been here with us in the room. Another important element to mention, mentioned already by Maria Luisa Marino, is the invitation for you to participate in the survey. For those of you in the room, there's a QR code in the last page of our program. And for those of you that are connected virtually, we have sent through the chat a link so you can access the survey. Now, I would now like to offer the floor to the Director of the Social Development Division from ECOAC, Mr. Alberto Arenas de Mesa. He is an important advocate for all these elements of public health. Alberto.
Thank you, Raquel. Good afternoon, everyone. Those who have been with us in person and online. As Raquel said, 250 attendance this morning with a peak of 400, 12 countries. So it has been a great success to be talking about these themes for us here at ECLAC and in this project of the UN Development Account Project. And I would like to begin, of course, by thanking the authorities who have been with us, Under Secretary of Assistance Networks, Eduardo Salgado, and the Ministry of Health of Chile, Dr. Bernardo Martorell, coordinator of the Reformed Ministry of Health in Chile, who has been with us all day, the Vice Minister, Montefar, from the Ministry of Health of Guatemala, and also with your team. I cannot see your exact, Diego, Cristian, and their names, but nevertheless, we thank you so much for having come all the way to Chile and suffering the Chilean winter. Well, and of course, we also thank the Vice Minister for Primary Health Care at the Ministry of Public Health of Colombia, Dr. Jaime Orrego, for his very interesting presentation online. Dr. Laurel from Linz, who sent us the video, and Graciela Ramirez for having participated in person. And also I would like to thank all panelists for their participation, as well as the discussants at this international seminar on health. And of course, both in person and online. As I said this morning, the French Development Agency, the IDB, OECD, Leo Cruz, and I would also like to especially thank Olga Toro from the School of Public Health at the University of Chile for being with us such a very important topic such as mental health for all of these processes. This is a silent crisis. And they are very valuable experiences that will, of course, will allow us to deepen in these topics. And placing at the center of this international seminar primary health care as a tool to move towards universal health based on the national realities in each country. And also highlight and thank the audience because at the Social Development Division, we never thought we were going to have such a turnout, but this has left the bar very high for coming seminars. And I thank everyone here and the team of interpreters who are there in the second floor greeting us, and the conference team with the technical people but everything worked out so well. And especially my team at the Division of Social Development and who organized this, Maria Luisa Amarillo, who is here and who has also acted as a discussant and of course supported by Antonia Nawade. And thank you very much, Antonia, Nancy, who always hides at the back there, Nancy Rivas and Mariana. Thank you all very much. I think that it all would end out very well. So, well, the various presentations that we have heard today, I believe, have, in fact, placed centrality in primary health care, in reforms, the transformation processes, but which I would call processes to face inequalities in health and also in the region in general, and the policies, the reform policies in the countries that are discussing this, such as we have seen today in different countries in the region. And we see of the 4 countries who took part in the UN Development Account Project. In the case of Chile, I would highlight the following. This morning, the Secretary Salgado, as well as Dr. Martorell, were saying the following. Look, the heart of our reform is primary health care. Well, you don't hear that every day. And I think that one way or another, this recognizes a diagnosis, a multidimensional diagnosis of PHC, which is reflected not only with addressing the health of people or the quality of people's health, but also in terms of the social determinants of health, of the various inequalities. And in that sense, I highlight this in the sense that primary health care is strategic, and that sees not only health, but also inequalities. And second, I would like to highlight something that Dr. Martorell mentioned. And I would like to highlight, and that is the cost of not reforming. Very often, health reforms are not done, are not implemented, as Maria Luisa was saying, because there are limitations, conditions, institutional conditions that do not allow you to do it. But often they're not done because they're high cost or they're financially high cost. The need of a tax reform to finance it and so on. But this is what it requires of a negotiation which is often not in the field of health, but often not doing the reform. For sure is more expensive than doing it. So placing that at the heart of our discussions on country policy and transformation is very important. I was seeing in the case of Colombia when the vice minister was saying that, well, look, we here in Colombia, we're doing reforms to social security, work, health, pensions. And he was saying, look, but we have a major issue. We have financial unsustainability to carry out what the law has empowered us to do. And this has to do with the financial sustainability of this. Now, in the case of Guatemala, well, Minister, if you like, I will hand the floor to you. In the case of Guatemala, I would highlight the following. The Vice Minister said some things that are very interesting and that had not been explored before at the seminar. This has to do with the levels of information the citizens have and how primary health care reaches the population, how this is communicated or not communicated. But at the end of the day, with a pandemic, how important it was to have in primary healthcare institutionality and to inform the population of the different policies being implemented. And as the minister said, in Guatemala, during the pandemic, this was done comprehensively. And that comprehensive policy somehow helped Guatemala to come through the pandemic. And also, he highlighted the different pressures that the health system is subject to, such as the demographic explosion and the epidemiological transition and so on. In the case of Mexico, Raciel Ramirez's presentation on the Mexican chapter on Social Security, this was very interesting. Maria Luisa also mentioned this in her presentation. We have been working on this for more than a year now, with our IMSS helping them with this process to estimate the costs. Because it's very interesting what Mexico said. Mexico determined a regulatory framework, constitutional regulatory framework, in 2022. And this led to an institutionality to take account of the mandate given by the Constitution. In Mexico, they said, okay, fine, that is the mandate that we have by the institution. And so what we need is to estimate the costs, because to implementing this needs human resources, institutional technology, but also financial resources. So there is a tremendous lot of work being done by IMSS, supported by us, to support the methodology, which is so important. Not only on account of the methodology, but rather that methodology will allow the government of Mexico to once again negotiate the implementation of this increased coverage, which set. Sharing these experiences, as Vice Minister Montúfar said, creates important space for collaboration at the regional level, and also sense of urgency in the need to address these structural shortcomings of the health systems. In other words, I would say that each presentation given today opens the way to take on this task pending since the pandemic to ensure the right to access for the entire population that does not depend on the ability to pay, but the needs of each person, and that are closely connected to other sectors, especially the other dimensions of social security, ensuring the financial sustainability, coverage, and the sufficiency of the benefits, and so address potential crises that may affect us in the future. Along this path of transformation, primary health care is essential and strategic. And this was not only the title of the seminar, but we were so convinced of the centrality of primary health care. But through PHC and our social determinants of health, together with the centrality of people and their ability to overcome the social determinants of health, on the one hand, this helps to reduce poverty, reduce inequality, and face the various issues affecting the health systems. Very well reflected in the various presentations. For example, I would mention panel 2 with Ricardo and Fran Bajo, IDB, Vice Minister of Colombia, Dr. Martorell as well. And they put up the various dimensions highlighting the relevance of investment, financial sustainability, human resources. How important human resources, investing in human resources in order to carry out the reform. And also innovation and tremendous potential of digital health, the digital transformation of putting this at the service of the changes in health. And in that sense, we saw that the various seminars of the panel had a common minimum, talking about the transforming capacity of primary health care, not only for health, but also facing inequality and leaving no one behind. Health is strategic, not only for life, but life quality. And it's also the ability to face different matters, such as reducing or facing inequality, and also that health be at the heart of the successful strategies for development. And when we say development, we're talking about inclusive social development and also sustainable. And so this international seminar, we address the challenge after the pandemic. And today, this is what we're facing, and create an opportunity that emerged during the pandemic. We were saying that the pandemic, the health regime was seen up top, and then we see that maybe it wasn't. So there's a task still pending to face this. And in that sense, we should highlight that there's a series of transformation in the health system in the region and that we need to move ahead differently. These health systems should change. But when they transform, we put four adjectives here. I mean, at least explain them: universal, integral, sustainable, and resilient. And in that context, for what? Well, for one way or another, they will allow us to have universal health, but also addressing inequality in the region. And knowing that these challenges are a priority, and knowing that they are transformations that are needed in countries, knowing that we need to invest more in health, knowing that we need to invest more in primary health care, one of the priorities should be convincing, look what I'm going to say, convincing not those of us who are here or the 200 online, but I think that we're all converted. But we must make an effort in our discussions and in the design of our public health policies. And that involves people who are not in this room and who are not online, but that they make decisions of the financial decisions that affect these health systems. And that happens. It is important to understand that we need to have a new narrative with regard to health that places health at the center. Like during the pandemic, health is put in number one priority. Today, we don't have the pandemic. We've overcome it. And in that sense, I highlight another words of Dr. Martorella. I've become a fan of Dr. Martorella. Another one of his phrases, Dr. Martorella said, the main wealth of countries is health. We at ECLAC say that the main wealth of the countries is people, but people without health do not exist. So we agree. But basically, this has to do with the fact that the health sector has a specificity in comparison to others. Health is the origin. Basically, if we were talking about this at the end of the morning, if we were at a seminar with ministers of education, most likely we would say that the biggest wealth of countries is their education, but that's not the origin. The origin is health, because at the end of the day, origin has to do with people, and people without health, they are no longer people.
So in this sense, to have different narrative that is not only linked to health, but that do talk to other sectors, to understand that health plays a role in economic development, in environmental development, social development, and other strategies can be as important as designing good health policies. This means that there will be an interest on behalf of other stakeholders to be able to progress, and they are so necessary in our region. So it is in this sense that I believe there is a dilemma in the health policies that we need to unlock, not only in terms of the designs, but how we are convincing those that are not involved in those designs. So finally, I would like to thank all of you, of course, the ones that have been with us virtually and the ones that are here in the room as well. Those of you that are staying in this room, and all our panelists that undoubtedly are always contributing to make progress in these different elements of health, to consider the challenges that the pandemic left, and to reduce inequalities, and to move forward towards the creation of an inclusive, social, and sustainable development. Thank you very much.
Muchísimas gracias.
Thank you very much, Alberto, for this wonderful summary, for highlighting the critical points and proposals on how to move forward and to consider new topics that will be related to other subjects, and to have advocates for the public health elements and other areas of social development and economic development. Thank you very much. Thank you very much to all of you for your active participation and for your commitment with the co-construction of fair and healthy societies. Good afternoon.